Moderator is Kay Igwe, who is from Columbia University in New York. And the first presentation is going to be given by Dr. Lawrence Kegeles, who is from the New York State Psychiatry Institute in New York. And he's going to be talking about brain MRS in psychiatry.
Good morning, and thank you for that introduction. And thank you for the organizers for this opportunity to present. So my topic is brain MRS in psychiatry. And I wanted to say by way of background that this, a lot of the material I'll be presenting today has been sort of inspired by a course that Christoph Yuchem and I have put together over the last several years under the auspices of this particular in-house organization at Columbia called the Columbia Collaboratory, who's targeting the support of development of new courses that are cross-disciplinary and cross-departmental. And in fact, we do aim this course to draw students both from biomedical engineering and from across the clinical departments at the medical center. And we think that's very appropriate for a course in MR spectroscopy. So I want to aim very directly at this overall question for the workshop. What are the barriers to clinical use? And focus that on barriers that we've seen in the field of psychiatry. And what I want to start with is a framework provided by this concept of biomarkers. And I think, in a way, it's very useful to introduce this concept because a lot of illustrious people, as you can see here, the NIH and the FDA in the United States have focused an entire work group on this topic. What are biomarkers? How can we define them more sharply, and how can we foster their development? So I want to just give that a little bit of attention and say that, in short, is what we need and lack in psychiatry and in applications of MRS with few exceptions. Including the exception that, that people have talked about here at this workshop of 2-hydroxyglutarate in neuro-oncology, but otherwise in brain science, and particularly in psychiatry, there's a complete lack of biomarkers, at least by a strict definition. So it's often stated that a requirement for a biomarker is that it have high sensitivity and specificity for classification, 80% on each. And some people would even say across the entire, I guess you'd say, confusion matrix of positive and negative predictive value as well. And as you can see, there are many types of biomarkers. The goal is classification. Classification need not be simply patients from controls. That would be the first one, diagnosis. But there are many others, classifying groups according to their risk of developing illness, or following the course of illness, predicting course, prognosis, monitoring treatment, treatment response prediction, safety. So it's a wide range of possibilities. The field is wide open. But bottom line, again, I'm repeating, there are no imaging biomarkers. That includes PET as well as MRI in psychiatry. I suppose if you broaden the boundaries of the field a bit, as is done in some institutions to include Alzheimer's disease, it's usually assigned to neurology rather than psychiatry. Arguably, the beta amyloid and tau PET imaging are heading in that direction, very close to becoming biomarkers, but they're fairly controversial yet themselves, particularly the beta amyloid. Other than that, in psychiatry, again, we have no biomarkers from either MRS or from PET. Now, to put in perspective these high demands of 0.8 sensitivity and specificity, I just want to do a quick review of a few actually accepted screening tests and what kind of sensitivity and specificity these are that have wide use already in medicine. So here's a review, a table taken from this review with examples. And you can see, for sure, there are some that are nearly perfect. Like, look at this last one here, this saliva PCR test for a particular virus. Taken from saliva, essentially perfect. 0.999 specificity, and perfect sensitivity. But a lot of them don't measure up. Look at all these whole class of hemocrit tests for colorectal screening. Quite low sensitivity, not in most cases approaching 0.8. So it's an aspirational goal, but it's a high bar, and it's one that we need to aim at to get our first biomarker accepted in psychiatry, widely accepted. So I want to ask, what are the barriers? What is it that gives rise to our inability to classify or discriminate? And what it is of course, high variance compared to the differences between the means of the groups. And what does that arise from? Well, there are technical sources. I want to divide it into technical and clinical sources. And the technical sources, especially in recent years, with all this very successful effort toward consensus criteria, major progress has been made. And many people in this room have contributed. So there are consensus pulse sequences, minimum reporting standards, optimized basis sets, optimal shimming, use of higher B0 field strength, and optimal use of ex-nuclear MRS as appropriate to the problem at hand. And on the other side, there are the clinical sources of variance. And what I want to do is make the case that it's our turn now. We on the clinical side need to make our contributions, need to think carefully about how these sources arise and what we can do about them. So a big one is sample heterogeneity. And some of that comes from diagnosis itself. That's a big problem. That is inherent in the DSM, in the way we make diagnoses in psychiatry. We make them through a series of criteria, and those series of criteria are flexible. And we introduce heterogeneity from the get-go when we make diagnoses. That's phenomenological heterogeneity. It's the way patients appear different, but presumably it's a very safe assumption that their brains are also going to have different neurochemistry corresponding to that. So that's something we need to work at. There are ideas that's a little beyond the scope of what I want to get into today. So let's take this as just part of the problem. But I want to focus on other parts of the problem that I think clinicians can work on right away. And that has to do with treatment status. Treatment status can be highly variable in an enrolled sample. Patients can be medicated or not. They can have different durations of treatment. They can be at different stages of illness. They can have different durations of untreated illness before their treatment began. All these presumably introduce variance. There's also brain anatomy. We're getting a little more tuned to that, and that is a big area where MRSI is going to be able to help, because we can accumulate many anatomic regions simultaneously. But it's important to be cautious about which brain region, not overgeneralize about conclusions that one draws from one brain region to others. And then finally, the potential time dependence of the signal that I'll have a little more to say about later in the talk. So again, here's where I'm focusing, clinical sources of variance. So I want to spend some time talking about one particular example that I'd like to drive home, and that has to do with use of 7T scanners now, moving to the the best technology in terms of B0 field strength, and looking at what that has told us so far in a very focused realm, the measurement of glutamate in schizophrenia. Now, in reality, this meta-analysis that I'm going to summarize here, it's a meta-analysis of all the studies done at 7T up to the point that this was done, which was a total of, I think, 9 studies. Looked at more than just glutamate, but for simplicity and to make the point, I'm going to focus on glutamate. So yes, 9 studies done at 7T. Mostly they used STEAM sequences, 2 out of 9, used laser or mega semi-laser because they were also looking at GABA. All the studies had comparative groups of healthy controls. Most patients were medicated. Most samples were 100% medicated, and the lowest medicated sample was 80% medicated. So by and large, these are patients in treatment with antipsychotic medication. The mean age of the patients was 28 years. So that is not first episode. That's not early in the illness. Many of you may know that schizophrenia tends to have onset in late adolescence or early adulthood. So these patients were, on average, ill perhaps 8 to 10 years already. And here are the results. In a forest plot, a standard way of representing a meta-analysis. Each line is a data point for a brain region from one of the studies. You see there are many more than 9 data points. And the reason for that is several of the studies looked at more than one brain region. And the tabulation here of the data points is by brain region. So the first thing I want to point out is these are kind of all over the map, even at 7T. I'm highlighting 2 of these. The thing I want to highlight about these 2 is really 2 things. One is these are pretty much the lowest and the highest mean. And by the way, the mean, if it's positive, means patients higher than controls. Mean if it's negative, patients lower than controls. But the other point I want to make is these are from 2 different studies, but they're the same brain region. So by and large, we're using the same technology here. I believe these were both STEAM sequences in both studies. Anterior cingulate cortex. The biggest glutamate deficit and the biggest glutamate excess in the same brain region, acquired at 7T. So it doesn't look like 7T diminished the variance for us in this series of studies. And in fact, as you eyeball this forest plot, it does look like it's all over the map. And the authors went ahead and did a study, a sub-analysis, an analysis of effect size homogeneity. And that indeed indicated what you would think just by looking at this diagram, that study-specific effect sizes were significantly heterogeneous. So what's the remaining problem in these 7T studies? Well, I want to slowly, over a couple of more slides, develop a suggestion that I have as to what's giving rise to this problem. The first thing I want to point out is, here's the overall study conclusion. The meta-analysis conclusion is negative. This is a significant negative effect size, accumulated or averaged over all the studies. And you hear that a lot these days. Glutamate is lower in schizophrenia. The 7T studies are telling us that. They're better. They're better than the 3T studies. I want to beg to differ a little bit, and I'll tell you why. Here are some 3T meta-analyses, a couple of 3T meta-analyses. These show that GLX was elevated compared to healthy controls in the striatum and the medial temporal lobe, and that there were no differences in the anterior cingulate cortex. 2 different meta-analyses. So why is there this 7T, 3T contrast? Why do we see glutamate decreases at 7T and increases or no differences at 3T? I want to start with the idea that I raised before and come back to it, the idea of medication treatment being a difference. So I pointed out, emphasized in fact, the fact that in the 7T studies across all 9 of them, the vast majority of the patients were medicated. I want to show you here a controlled medication treatment study. This was done at 3T, and it showed a couple of interesting things. By controlled study, I mean patients entered who were medication naive. They had never previously been treated. They were first episode, early in illness, and they were treated within the study with a particular drug, uniformly, the same drug, risperidone, over a 4-week period. And what you can see here is that the patients were higher than the controls at baseline, and that after 4 weeks of treatment with risperidone, they dropped to levels that were indistinguishable from the control levels, either at baseline or 4 weeks later. The controls were imaged twice as well. And the same author has gone on to replicate that study with another technique. So the first technique was, I believe, press with echo time of 30 milliseconds. These are striatal data acquired in that fashion. The second study used megapress and did not only this voxel, the striatal voxel, but also one in the medial prefrontal cortex, all the same findings replicated. In addition, there was a review and meta-analysis of treatment effects that included 32 studies and drew part of these same conclusions. What it drew was a conclusion that frontal GLX levels were significantly reduced after treatment. What it lacked was, as I'm pointing out here, control group comparison. So it's unknown in these studies, across these studies, whether we can draw this conclusion that in fact the patients were elevated before treatment. We don't know that, but we do know that the medication reduced their glutamate levels across this fairly good size sampling of studies. There's also a 3T mega-analysis. A mega-analysis differs from a meta-analysis in that the input from each of the contributing studies, and there were 45 contributing studies, the input from each of the studies is actually the individual data points, not the mean and standard deviation brought in a statistical fashion. On the other hand, there was the task of harmonizing the data across the 45 studies, and perhaps the technique for doing that was a bit questionable. I don't want to get into that. It's beyond the scope of what I'm going to talk about today, but they were compared across the 45 studies, and these conclusions were drawn that antipsychotic dose was negatively associated with medial frontal cortex glutamate, and drew the conclusion that glutamate may in fact be reduced through effective antipsychotic treatment to levels the same as or even lower than those observed in healthy controls. So here are the conclusions that I want to draw from this series of points that I made, is that ultra-high field 7T was not able to reduce the variance across the brain regions and the studies. I don't think that's a technical problem. It's not a technical issue. For the reason I've been claiming, the evidence I'm presenting, not quite a smoking gun, not a decisive meta-analysis that says this is so, but I'm saying I've given you some indications that possible sources are medication status, and possibly also brain region. So in short, there are apparent cohort differences. And the main cohort difference that I've already mentioned is that the samples studied in the 9 studies analyzed in the 17 meta-analysis were medicated by and large. I wouldn't say that at 3T they were unmedicated, but a much larger percentage of them were unmedicated. So that's a factor that could have begun affecting the data and causing the higher values that we saw in those lower field meta-analyses. I don't think it's the technique. I don't think it's the scanner. And I just want to summarize again. Once you engage a medicated sample, you're introducing a lot more than the direct effects of an antipsychotic medication on glutamate. And we can talk, if anybody wants to, about mechanisms by which a dopaminergic blocker, D2 receptor blocker, could lower glutamate. There are some known methods. It's a little beyond the scope of what we need to get into, but it's empirically shown by those studies that I showed you. There's not only this reduction in glutamate, but there are all these other variables that are associated with treatment that get introduced that aren't well controlled across these studies. There's the dosage. People get different doses of medication when you're not doing a simple controlled study. There's the variability of the specific choice of medication. There's adjunctive treatment. Many patients get additional drugs besides their antipsychotic. There's the duration of treatment. People can be studied at a different stage of treatment. And of course, there's a duration of untreated illness. How long did they go in their illness before they received the medication? So what I'm, in short, advocating on this limited amount of evidence that I've shown you is, please, if at all possible, 7T studies of unmedicated patients in schizophrenia. They would be very, very informative. There are none yet. And I have a hunch that if we do them, they'll show similar results to the 3T studies. So that's the responsibility really of the clinicians. And it's very hard. I mean, I fully understand why these 7T studies studied medicated patients. They're far easier to recruit, particularly in the United States, particularly in places like New York City and Baltimore, all the big cities. Probably so here in Europe. But the sample that I showed you done at 3T that was unmedicated and medication naive was done in Mexico City. And perhaps, unfortunately for the patients there, unfortunately for research, those patients are abundant in Mexico City. And my colleague there, Dr. De La Fuente Sandoval, whose studies I quoted, is still able to recruit such patients into his studies. And the great news is he's working on getting a 7T camera. So that summarizes what I wanted to say about medication status. I want to go very quickly through a couple of other possible contributions to variance in MRS studies. Time dependence of MRS studies. I just want to recap a little bit about functional MRS. We heard an introduction to a talk on this topic on Monday. There's also in existence already a review of 14 such studies that in different ways with different types of stimuli, and they're listed here: visual stimuli, motor tasks, thermoregulation, heat and cold application, executive function tasks, learning and memory, cognitive control, by and large across these studies with designs similar to what's used in bold fMRI, boxcar, repetitive on-off conditions for the task, showed elevations in glutamate. And Jeff Stanley, who wrote this review, has this diagram in which he shows that in stimulus off versus stimulus on conditions, he hypothesizes that this is explainable by a change in excitation inhibition balance, and shows spectra in which there are slight increases in the glutamate peak. And I want to say just a little bit more about that. That in this review of 14 studies, half were at 7T, the rest were at 3 or 4T. One was done with semi-laser, 2 with special, and all the rest were done pretty much half and half with steam or press, by and large at short echo time. And the main finding is the same as what we heard on Monday, that there was a several % increase in glutamate across many of the task conditions. I want to say some comments, make some comments about the significance and about some caveats about this type of study. First of all, I want to say that any improvement in controlling the conditions, the experimental conditions under which our subjects participate, is a step forward. So that's a benefit of this type of study, including simply presenting a checkerboard pattern or a blank field, rather than simply telling our patients, go in the scanner and relax, which is what we do. It's very uncontrolled. It has the potential for characterizing EI balance in normal brain and also in disturbances in illness. But I would say that the underlying physiology still remains unclear. We heard a couple of interesting hypotheses on Monday, which is that glutamate in the vesicles, presynaptic vesicles may be less MRS visible compared to the glutamate released into the synapse. But nevertheless, given the steady state that's assumed of raising and lowering in a repeated boxcar design, if we're in steady state, we nevertheless, I believe, have to cycle through the glutamine cycle to restore what's in those synapses for the next vesicles for the next release event. So there are questions about whether that kind of cycling through the glutamine cycle can occur, and how rapidly, and what are the rate limiting factors for that. So I believe the underlying physiology is a little more development. And I think in addition, if we're going to approach something like what the work that's being done with bold fMRI, that we need not only the time scales, but also the spatial resolution to undergo significant improvement. I think I'm going to skip the next topic in the interest of time, because I think I'm a bit over, and just summarize by saying that we have a need for neuroimaging biomarkers in psychiatry. That's the big barrier, the way I see it, to clinical applicability. The major barrier to clinical use remains attaining adequate sensitivity and specificity, the ability to classify groups sufficiently sensitively. Avenues for future progress are reducing clinical heterogeneity in the ways that I mentioned. That there is also a critical role of brain region, and MRSI is going to be a major step when we have that available. We need to optimize the challenge stimuli and the task conditions for fMRS. And basically, classification power enhancement via multivariate approaches will help as well, exploiting the fact, this is the part that I skipped, but exploiting the fact that in fact we get a large number of variables, many of which are relevant to clinical status, all in one experiment. And we want to see if we can optimize that situation to enhance power as well. So finally, I want to acknowledge the people that I've worked with over the years, people in my group and colleagues, acknowledge this financial support we've had, and to thank all of you for your attention. Thank
you. Thank you very much. Excellent presentation. Do we have questions from the audience or online?
Hi, thank you for your talk. That was really interesting. So I'm looking into going into this type of research. And what's become quite aware for me is also that there is like a lack of these like unmedicated studies in schizophrenia. But then, and we would expect like glutamate to change if like they're being medicated like properly. But how are we meant to like scan these patients if they're like hallucinating, especially at 70? It seems kind of like not really that ethical. Probably it's quite disturbing for them. Do you have any advice?
I'm sorry, I missed a few of your last words. I couldn't quite hear.
So I agree about like, there's like a gap in knowledge about scanning patients that are unmedicated. So, but then if they're unmedicated, they're going to have a lot of hallucinations and like, they're going to find being scanned at 70 quite difficult. So do you have any like recommendations to scan them if they're unmedicated?
So in my experience, I don't have experience scanning people at 70. I'm not sure that it would be that much more difficult. What I have found amazingly in my career is that it is not harder for patients to do an MRS scan than it is for healthy controls. People that I've had who have panicked in the scanner have been as likely or more likely to be healthy controls than patients. It's amazing. It's remarkable to me how well patients with schizophrenia do over more than an hour in a scanner.
But then if they're medicated, they won't be having hallucinations and things. But then the scanner, like all the stimuli and things may like bring about hallucinations.
Yeah. It's not a deterrent. And people are not hallucinating every moment necessarily. By and large, I think if you prepare a subject for what the environment is going to be like in the scanner, they generally tolerate it very well. Truly, I'm going to repeat, I think the big barrier is finding the unmedicated patient, recruiting them. That's the biggest problem.
Thank you.
Thank you for this really nice review. I had two questions. The first one is relating to the variance that you were discussing earlier by glutamate measurements, especially from my experience, often in the papers and the analysis that they're doing, they're not necessarily following the consensus paper, the recommendation that people here have established along the years, especially for the macromolecular baseline when they're doing, for example, a T-press at 30 milliseconds. And so there's a large variability on the glutamine concentration introduced by the fact that the baseline is quite often chaotic. And second question is, you haven't commented on other biomarkers than glutamate, for example, mannitol with the inflammation maybe being a really important or interesting thing in psychotic disease and spectroscopy.
Sorry, I missed the second part of your question.
With mannitol and inflammation eventually taking a role in the
role of inflammation,
for example, in schizophrenia.
Did you say the role of inflammation?
Yeah, inflammation.
Yes, by all means, that was among the slides that I skipped at the end, for sure. And it might well be related to the glutamate abnormalities, if that's the point that you're making. As far as the analysis point, one point that I do want to make is that, I featured the two studies by De La Fuente Sandoval using very different methodology. One was press TE 30 milliseconds. The other was with megapress. And the analytic methodology is very different. They're both done at 3T. The analytic approach is entirely different. There's spectral editing in the second case, and yet the same findings. So I find that reassuring, despite the caveat that you raised, which is well taken.
I think we can do one more question if it's quick.
Yeah. Well, one of the first slides that you show, the glutamate, looked pretty depressing, especially how the data was scattered. What gave you the confidence that the technical issues and like a pulse sequence and so on didn't play a role at 70? Because 70 is not always 70, spectrum.
Thank you for raising that. I don't feel that I'm in a position to critique the technical expertise of the people who did those 70 studies. I'm sure you are, and it's a valid point. I just assume that a center that has a 7T scanner may well have excellent technical support in both running the scanner and analyzing the data. But I didn't specifically critique that myself.
All right. Thank you very much, Dr. Kagan. Okay, now for our next speaker, Dr. Otto Rapalino from the Martino Center for Biomedical Imaging in the Department of Radiology at Mass Gen in Boston. Will be speaking about brain MRS in cancer.
Good morning. I would like to thank first the organizing committee for the invitation to present this lecture today. I have nothing to disclose. This is the outline of my talk. First, a brief introduction, talk about potential applications of MRS in brain tumors. At the end, I'll present some interesting cases, and finally, a summary. I will start saying that brain cancer is not a single disease, it's a quite of heterogeneous group. This is an kind of an overview. The different types of brain tumors, we can see they're quite different. And these are the glioblastomas. These are the primary CNS tumors. I want to include in here metastases that represent a significant proportion of intracranial tumors. So a lot of the things that we can use as a biomarkers that are going to be different among different types of tumors. This is about the secondary CNS tumors, the metastases, and they do represent a significant proportion of brain tumors, at least as twice as many cases of secondary brain tumors, metastases, compared to primary brain tumors. Regarding IDH1 mutations, they are also quite variable, the prevalence of these mutations. We can see how for astrocytomas, low-grade astrocytomas are quite prevalent, but other tumors, for example, like ependymomas and some less common tumors, we're not going to see IDH1 mutations. So-called applications of MRS in brain cancer. The first one is to differentiate between neoplastic and non-neoplastic disorders. This is kind of bread and butter application in a hospital. So often the question is, what we're seeing, that mass-like lesion, is it really a tumor or is it a non-neoplastic lesion? Obviously has a huge difference in terms of the approach. This is an example of this, and we can see how this lesion in the right parietal region, there's a blurring of the gray white matter differentiation. There was no enhancement. You can see that there is no significant local mass effect. So is this a low-grade astrocytoma, or this is some kind of developmental lesion, such as a focal cortical dysplasia? Spectroscopy here is the best tool that we have to differentiate these two pathologies. In this case, we can appreciate how, in general, the spectra sampling this lesion compared to the contralateral brain parenchyma, they look very similar. Myelocytol, choline, NAA, they look identical. So this is very reassuring, and this is allow us to follow this patient clinically without a biopsy. This is a different case. And this is a good example about multimodal imaging. We don't do a spectroscopy in isolation. In cases like this, we do spectroscopy with conventional images, post-contrast images, perfusion, SWI, etc. We can see how the spectrum looks quite interesting, quite worrisome, but everything else is reassuring. And taking in this context, the lack of elevated perfusion, CBB, the pattern of enhancement, this continuous pattern of enhancement, the presence of lactate, lipids, even the mild elevation of choline, all this is compatible with the tumefactive demyelinating lesion. This was a home run for a spectroscopy. This case we had it 8 years ago or more. And I still remember that day because this spectroscopy shine in this moment above any other modality. We can see how there was an heterogeneous enhancing mass. There was kind of focal elevation of CBB values, but the spectroscopy was very abnormal. We had these gigantic lipid peaks. The short echo time spectroscopy, look at the size of these lipid peaks. And we prospectively suggested that this patient had a tuberculoma. And it's not something that we see very often in Boston, but we were able to diagnose this patient before surgery using a spectroscopy. Cases like this we see quite often, where the question is this an infert or is this a tumor? And we can see in this case, clearly there's elevation of CBB values. The spectroscopy is very abnormal, elevated choline, increased NAA, etc., compatible with a high-grade glioma. Primary or metastatic tumors, we can use a spectroscopy also to help us to differentiate these two types of neoplasms. Looking at the surrounding T2 hyperintensity, looking at spectroscopy, is it very abnormal or normal or mildly distorted? In these cases, we can use, if it's very abnormal, it would be like a GBM. If it's relatively normal, like in this case, would be a metastasis. High or low grade, there is a good correlation between how abnormal the choline over NAA is with the grading of a glioma. So the higher the choline to NAA ratios, more likely it's going to be a higher grade. Usually for low-grade glioma, we see only often even normal ratios to mildly elevated. But like in this case was a little, so mild elevation of choline, NAA was significantly decreased, but this goes along with a low-grade astrocytoma. This is an anaplastic astrocytoma, but I want to point out, even in this case, MRS allow us to sample the tumor and identify some areas that are likely higher grade. Look at these areas towards the center of this lesion. How abnormal, how significant increase are these choline to NAA ratios. These are likely areas that were not sampled, and they're likely to reflect the GBM. This is a classical glioblastoma, classical spectroscopy with elevated choline, markedly decreased NAA. MRS markers of a specific histology, so we're getting towards 2HG, but there are other markers that you should be aware of. Minocytol, I think it's really an undervalued marker. We see it constantly, how important it is, but not a lot of people are aware of this. Lipids, primary CNS lymphoma, taurine from medulloblastoma, and some others. 2HG and IDH mutations, as we know. So 2-hydroxyglutarate is a marker of this associated dehydrogenase mutations. This was the initial paper in Science back in 2008, describing the presence of these mutations in brain tumors. So the detection of 2HG is quite variable with MRS, and it's interesting, it will depend, obviously, the concentration of 2-hydroxyglutarate within the lesion and the volume. So small lesions, we're going to have a harder time to identify the presence of 2-hydroxyglutarate. 2 IDH mutations produce a better prognosis for the patient. This is the Ovidius paper. This is one of the original papers describing the presence of this mutation, the fact that we can identify 2-hydroxylglutariate with MR spectroscopy. Around the same time, a group led by Chang-Ho Choi published similar results. This was in Nature. The same year, there was this very nice paper describing the different resonances that we can use for identification of 2-HG. So you can see how there's all this cluster of resonances between 2 and 2.4 ppm. These are two papers that analyze the accuracy of detection of 2-HG with MR spectroscopy. The paper on my left side is quite interesting because they analyze the accuracy, the sensitivity, and specificity for the initial diagnosis using single voxel and 2D CSI, and also compare with the follow-ups after treatment. And in general, sensitivity is quite high. The specificity can be moderate to high. So there are two very interesting papers about this. This is an example that we had with Ovidio a while ago. Just to, in this case, this was an edited spectroscopy. We can see this left posterior single mass. And these are the results of the LC model analysis, clearly documented the presence of 2-HG. Since then, we have moved towards the use of ATE of 97 milliseconds for detection of 2-HG. This is another case. Even without a spectroscopy, I know that this is an IDH1 mutant because we did multimodal imaging, and there is something called the T2 flare mismatch that is 100% specific for the detection of IDH1 mutant tumors. And these are the 27 millisecond spectroscopy, and through LC model, it was confirmed that there was a 2-HG. This is from a video also. You can see that now we can display three-dimensionally the presence of 2-hydroxylglutariate. Let's talk about very quickly about minoxidil. Minoxidil, again, is a kind of under use metabolite, and it's very important. It's a marker of astrocytic gliosis. It's also a marker of intercellular osmoregulation. And we can see how in some cases, like in this case, we can appreciate that the NAA is not significantly decreased, choline is not elevated, the lesion is very small, just highlighted, it's in the left parietal region. But it's interesting that the choline was not elevated, but minoxidil, if you look carefully, it was elevated from the lesion compared to the contralateral side. Again, a marker of reactive astrogliosis and glial tumors, as described in this paper. And this, I'm getting to this statement, how we're going to see tumors where there's no elevation of choline, but there is elevation of minoxidil. And we'll see this frequently. It's a very important marker. This is, again, a patient with gliomatosis cerebri, similar concept. You can see elevation of minoxidil, like in this case, it's an MGH case. We have a tumor crossing the corpus callosum, clear elevation of minoxidil, but interesting, the choline was not elevated. Another case, look on the left hemisphere, all infiltrated by tumor, but choline was not elevated from that lesion. So minoxidil is clearly an important marker that you should use in your clinical practice. Lipids, so in my mind, homogeneous enhancing mass with prominent lipid peaks lymphoma should be considered until proven otherwise. We can see an example of this in this case. There is restricted diffusivity within these lesions, homogeneous enhancing, mild elevation of CBB values, and look at the size of these lipid peaks. And this is a rule that sometimes I forget, but it comes back every time. When you have a case with prominent lipid peaks and you don't know what it is, you should consider lymphoma. Another case, look at the size of these lipids in this patient, right frontal mass, homogeneous enhancing lymphoma. Taurine is a marker that has been published associated with medulloblastoma. You can see in this case requires special techniques because of the potential overlap with minocytol and choline. We can see adjacent to choline, we can appreciate taurine. So you require special spectral editing sequences for this. And it can be very helpful to differentiate specific subtypes of medulloblastomas, like in this case, a group 3-4 and a sonic hedgehog medulloblastomas. Definition of tumoral borders and the highest grade component. You can see we can use spectroscopy to target the area that we're going to find the highest grade component. Like in a case like this, obviously looking at the choline over NAA maps, you can just target with biopsy that area that is the hottest. Post-treatment changes, we can use a spectroscopy to differentiate radiation necrosis from recurrent high-grade tumor, and also to differentiate pseudoprogression, more like early post-treatment changes from progressive tumor. In a case like this, we see both. We see the presence of tumor in the kind of adjacent medial to this mass-like lesion. And then by within this mass-like lesion, it looks more like radiation necrosis with prominent lipids, kind of decrease of most of the metabolites, no significant elevation of choline. And this is how to use spectroscopy to differentiate the earlier post-treatment changes, pseudoprogression versus recurrence. Clearly, there is elevation, higher choline over NAA ratios when there is recurrence. MRS during anti-neurogenic treatment, there's a medication called bevacizumab that will remove the presence of enhancement, will affect the perfusion, but the spectroscopy is the best tool that we have to follow these patients. Like it was published in this paper, clearly showing the value of spectroscopy, identifying the areas of tumoral infiltration. Prognostic value. We can use spectroscopy not only to identify the presence of 2-HG that has prognostic significance, but there are other ways that we can use spectroscopy to kind of help us to define the patient's prognosis. Now let's go review some interesting examples highlighting the value of MRI spectroscopy. This is a kind of routine case, but clearly showing how important spectroscopy is in a clinical setting. You can see this is a kid who was diagnosed with a pilocytic astrocytoma, had a resection, and now presenting with new areas of abnormal enhancement. We did perfusion. Perfusion shows mild elevation of CBV values. We were already suspicious, but the spectroscopy confirmed the presence of tumoral recurrence. So what is the value of spectroscopy here? Is increasing my clinical confidence that we're seeing here is recurrent tumor. No question this is what's happening here. You can see clear elevation of choline, decrease in NAA in this case. This is another case. How to do, we do spectroscopy in the brainstem, quite a difficult area. So we do, instead of doing actually as kind of conventional way, is do it sagittally. So we do sagittal spectroscopy. Sometimes we do coronal spectroscopy in the brainstem to better sample these lesions. This is a young patient, 28-year-old, with a mass in the pontomedullary junction. Biopsy is quite risky, but interestingly, with the spectroscopy, we detected 2-hydroxyglutarate in this tumor. And not only that, the patient had a liquid biopsy where they identify the IDH-mutation. So the whole clinical team was very comfortable to proceed with treatment because they had 2-HG identification through MRS and they had a liquid biopsy. This is a patient with another pilocytic astrocytoma and very similar case, clearly showing evidence of recurrence in this case. Glioblastoma, everything pointed at tumor. The MRI, elevated CBV values, abnormal spectroscopy. We told them this is tumor. The patient went to biopsy, came back negative. And it shows you that sometimes even biopsies can be wrong and spectroscopy can be right. And also the other MRI techniques. The patient went back to surgery, they identified the glioblastoma, they resected. This was a really a unique case. I think there was another case report of this. This is not a neoplasm per se. It's an extraaxial lesion that can present like a neoplasm. It's called an epidermoid cyst, can produce local mass effect, compress adjacent areas. You can see the lesion right there in the left suprasellar region. But the spectroscopic pattern was so unique. Look at this spectrum, quite unusual. And then looking in the literature, exactly the same spectrum had been published with epidermoid cyst. Venous infarct, again, this is the question about neoplasms versus non-neoplastic lesion. In this case, there is no elevation of choline. Spectroscopy looks relatively kind of mildly abnormal, confirming this enhancing lesion was a venous infarct. So to summarize, MRI spectroscopy is an important diagnostic technique in many clinical scenarios, but especially for brain tumors, a very important technique. And we do this routinely, more and more. Say, Eva can confirm this, that last couple of weeks has been more and more spectroscopy cases. And I think likely it's because of the referring clinicians and seeing the value of doing spectroscopy in the way we do it, supervised fashion, whole team approaching these cases. And it's when we use spectroscopy, it's not in isolation. We do a multimodal imaging approach. We do perfusion imaging, conventional imaging, etc. Increases my confidence what we're looking at, clearly. Looking at a brain tumor without spectroscopy is not the same. But with spectroscopy, and clearly more confident making a diagnosis. And we're facing a lot of technical and reimbursement challenges in the US for spectroscopy. Still many insurance companies considering spectroscopy an experimental technique. But it remains a crucial and very sensitive imaging tool for the evaluation of intracranial neoplasms. Thank you.
Okay, so if you have questions.
I cannot hear your video.
Yeah. I'll come to you. I'll come to you.
Hi, a very nice presentation. I think it's the battery. It's a very nice presentation. I think you are one of the rare radiologists that have a very high opinion about MRS and using it in the clinics. So in my experience with interactions with other radiologists, I hear more skeptical opinions about, not about the value of it, but more about the performance, how successful, I mean, the rate of successful examinations and cases, and how many times you can actually use the data to make a clinical decision or draw a conclusion. In your opinion, I'm curious what do you hear from other radiologists with which you interact? Like, do they have, like, how do they see at the current moment the this imaging modality? And second is like, what can, let's say, we or that do also technical development can do to, or do what radiologists would like to see in order of performance and other things to make them see this methodology more favorable or use it more often in clinics and maybe get it reimbursed and so on. What do you think it needs to be done, or what should we do?
Yeah, thank you, Video. It's a very important question. And it's because of many radiologists are used to that those spectra that are all degraded by artifacts, often non-diagnostic. So they think spectroscopy, there's no value. It's always like degraded by artifacts. And why am I using that? Why am I adding to the protocol? But the difference is made when it's a team that is supervising every case. So our fellows are supposed to tell me or tell Eva when there is a spectroscopy case. And every case, I'm protocoling it, we're supervising it, we're doing it, and I'm reporting. And clearly the value comes out. The quality improves tremendously and interpretation becomes very accurate. So I think that it's important for the radiologists to train themselves to recognize what are the findings with the spectroscopy. And they need to realize that they need to put more attention about how it's acquired. Technologies, MR technologies are very uncomfortable acquiring spectroscopy because in many institutions, they don't do it routinely. So it's important, if you want to do in your institution, there must be a team approach that you should kind of really supervise the cases, at least at the beginning. So I think that's key for success, to make it better. Wish list, I was thinking about a slide for that. I think that it would be great, for example, it will improve the recognition of the technique if we could make sequences that are more resistant to artifacts, obviously, faster sequences. You know, 10 minutes in a busy clinical center is a big deal, right? If I'm there, nobody says anything. But if I'm adding a 10-minute sequence, right, somewhere else, why are we doing a 10-minute sequence, right? So definitely a faster sequence would be ideal. Whole brain acquisition, I'm very excited about that. That would be amazing because it would be another sequence that you add. And the issue with the multiple echoes, because sometimes we need to have multiple echoes to provide the clinical answer.
My question was, you said that myoinositol is a very important marker. I think your spectra were from 3 Tesla. So at 7 Tesla, we see that we can nicely separate glycine from myoinositol. And I think we see some benefit in this, but you haven't mentioned glycine at all. And also the second part would be at 7 Tesla, we see better separation of glutamine and glutamate, and we also find interesting results there in brain tumor. So what's your opinion about these biomarkers?
Yeah, all 3 of them have been described in brain tumors. So it is possible all 3 of them are relevant in these cases. But at 3T, we see that peak and the expected resonance of myoinositol. And it is important just to recognize it. If it's glycine or myoinositol, right? The importance is that it is a marker of neoplastic infiltration. And these are cases where choline is not elevated very often. So that's why it's important to recognize it. But yeah, I mean, I hope that we can get to a point that we can do routine 7T imaging for our patients. And we will, that at a time, we'll be able to differentiate what could be myoinositol, glycine, or even using GLX in some cases. Yes, I think all of them, they have value. I mean, these are cases that we're trying to identify the presence of neoplastic involvement. So all these markers are important.
But choline is not.
Yeah.
How do you interpret that from a cellular perspective? Is it because choline is more of a marker of an active inflammatory state, or how do you interpret it?
Yeah, very interesting. So I think that maybe these are cases of gliomatosis cerebri. So they are intermediate tumors. So I think that maybe there are somehow membrane proliferation in this area, kind of the production of the release of choline is not very high, but we're seeing maybe more microglial activation, maybe some kind of, maybe they are internally, there's more astrogliosis. The problem is that we don't have a good pathological correlation in these cases. And they are, so far have been rare case reports, but we do see it clinically. So at some point, we're going to have that pathological correlation just to find out why these tumors are different, but we clearly see it.
So I'll take the last question. Yeah, I'll take the last question.
Please.
So it's a longitudinal question. So as far as the tumor environment itself, I know that it's a heterogeneous environment, so many different cells. So when you're thinking of doing a longitudinal study, my suspicion is that if you image different places, even if you're doing it within the same study, if you image different places within that tumor, you're probably going to see a different spectroscopic signature. So how do you ensure, like in the case of treatment, how do you ensure that you're imaging the same location each time so that you actually are measuring a change in, the environment, at least in that area?
Yeah, I think the best example of what Ovidio is doing with 2-hydroxyglutarate. So Ovidio published a paper just using the 2HG 3D maps to assess treatment response. So I think that it's just the possibility of using 3D volumetric MRS, and that will be the best way to kind of avoid these sampling errors. So I think that we're going to get to that point that we're going to be acquiring more and more whole brain MR spectroscopy. So it will be much easier, it will be more reliable to follow these patients over time. I think that's going to be the key. Until then, we just need to confirm that manually that we are at the same level, but hopefully we'll get to that point that we're going to see more and more of these whole brain three-dimensional CSI sequences in the clinical setting.
Okay, thank you, Dr. Amplino. So in the interest of time, we should move on to the next speaker, who is Dr. Petra Poels from the Department of Radiology and Nuclear Medicine in Amsterdam, the Netherlands. And she will be talking about MRS in pediatrics. In terms of asking questions, I do encourage the younger people in the audience to ask questions. We don't just want questions from the old people like me and others. So remember, there's no such thing as a dumb question.
Thank you very much. And thank you for being here. And especially thanks for inviting me to this very nice conference. Oops, and another one. Yeah. I'll be talking, of course, about neonatal MRS, about metabolic disorders, and a little bit about predicting the effect of treatment. But I would also like to share with you some methodology aspects. And that's both field strength and which metabolites to include. To start with the first one, what field strength? So I would like to ask you to whether this is to consider whether this is a 7T scan, a 9.4 T scan, or maybe another one. Please raise your hand if you think it's a 7T scan. Thank you. And please raise your hand if you think it's a 9.4 T scan. Oh, even great. And please raise your hand if you think it's another field strength. Okay. The majority is correct, at least if they think and agree with me that it's a scan at 3 Tesla, obtained in this case with a press sequence at an echo time of 35 milliseconds. This is a sum spectra of 68 spectra of parietal cortex over a diversity of patients, mainly young patients, of course, because it's about pediatric MRS. But not only 3 Tesla, but also 1.5 Tesla is a perfect field strength for children, at least. Neonates, we often, when they suffer from perinatal asphyxia, so a shortage of oxygen during birth, they are typically treated with hypothermia to allow the brain to recover. And then subsequently, they are scanned with clinical MRI and MRS to determine the situation at that stage. That's done at 1.5 Tesla. And I will show you examples done at a Siemens Avanto and Solar scanner with a normal head coil. And in fact, we didn't possess a baby coil or an incubator. The single voxel press spectra are typically done in a relatively large volume of interest of 14 milliliter, but it's only 32 acquisitions. So within 2 minutes, you can get a spectrum like this at 1.5 Tesla. This is a spectrum, actually a normal MRI, but also a normal spectrum for a term neonate at the age of about 5 to 7 days. And of course, if you know how normal brain looks like in an adult, there are differences because due to the development. So the NAA is a bit lower and choline and minoxidil are a little bit higher at this age. Of course, there are also children with a moderate or poor situation. And then you can get examples like shown here on the left and the right. And we often see increased lactate and lipids. We often see increased glutamine. And occasionally we see a broad or also a kind of double choline signal. And of course, also low NAA in these cases. Generally, the spectra have an excellent quality. I now collected 190 spectra of these patients. And of those 190 spectra, all included, the median full width of half maximum as obtained with LC model is 0.03 ppm, which is 2 Hertz at 1.5 Tesla. This is because the brain tissue is very homogeneous. It has a low iron content, so the shim is can be very good. Of course, when the baby moves, you also get broader spectra or really broad spectra, and then you go up to, say, 4 or 7 Hertz. But still, these can be used, for instance, to exclude the presence of lactate. But of course, glutamine and glutamate are not possible to discriminate in these spectra. But while doing these neonatal scans in the past years, we at some point detected propylene glycol. And this is a doublet that you can see here at 1.13 ppm. And of course, at first we were puzzled, what is this metabolite? But then at some time we were, we noticed the paper of Ernst Cady already from 1994, who already described the presence of propylene glycol in babies. And where does this propylene glycol come from? Well, it is a solvent, or it is a part of the solvent of phenobarbital. And phenobarbital is one of the treatments that is given to the neonates when they have convulsions. And this propylene glycol that improves the solubility and the stability of these drugs. But it has also short-term side effects. I mean, propylene glycol is antifreeze, which you also put into your car during winter. So the propylene glycol dose in the preterm and the term-born neonates is already typically quite far above the recommended safety limits. You can't simply help that. But because they have immature liver and kidneys, the rate of elimination is also quite slow. And it appeared that since about 2016, the phenobarbital formulation has been more diluted by the supplier. So when you use the same phenobarbital dose, the PG, so the propylene glycol dose, increases by a factor of 2 to 5. And we, actually accidentally discovered this with spectroscopy. And you see here 4 cases where you see here, all of them, you see the propylene glycol, and it's not only a doublet at 1.13 ppm, but also here signals around 3.8 and especially at 3.5 ppm. You see a little bit lactate here. Here also you see the propylene glycol, lactate, again the double choline, some glutamine. In this case, it's a cerebral stroke and a really devastating effect on NAA and creatine, but high levels of propylene glycol and lactate. And in this case here at the right bottom, again, you see some of the propylene glycol, but in this case, we also see enormously elevated glutamine due to hyperammonemia and a metabolic disorder in this kid. Because we at that time had collected so many examples, we also noticed that the level of this propylene glycol, varies, of course. And it varies because the total dose varies that the children have been given, but also the timing until the dosage of this propylene glycol or the phenobarbital and the time of the MRS scan. And so using all those data together, we used the first order kinetics model to estimate the half-life of this propylene glycol in neonatal brain. And just to remind you here, this is the full width half maximum of these spectra, 1 Hertz. And the Kramer-Rauer lower bounds of the propylene glycol is quite low. And we estimated, based on all those data, a population-based half-life of about 40 hours in the brain. And until then, the literature has observed some plasma values, which were 20 hours. And in adults, the half-life is only 2 hours. So there's a huge difference. So based on all those findings, and also because the recommended thresholds are already quite high in the neonatal intensive care unit, there's a special attention to keep this PG dose as low as possible. So fortunately, the manufacturers of the pharmaceuticals have modified their phenobarbital again. And since 2019 and 2020, we hardly detect any propylene glycol anymore, which is of course very good news. Of course, the MRS is not only done in case of the asphyxia and the hypothermia treatment, but also because sometimes the kids have seizures. And the question is this due to the non-ketotic hyperglycemia? And this will lead to an extreme elevation of glycine. So this is a spectrum, a neonate with seizures and a short echo time spectrum. And you see here, when you fit the spectrum with a, say, a normal basis set without glycine, so an enormous fit of the myoinositol here in blue. There's some also misfit or small residuals. But of course, we know, we can expect that there's a glycine in this case. And if you fit it with glycine and inositol, there's a clear, or you also fit the glycine as a very high level here in green. But of course, it's quite uncertain due to the overlap with the myoinositol. Of course, the solution is here to use a long echo time. We used here 135 milliseconds, but also 270 could be possible. And then you clearly see that the high glycine peak here in green, the 3.5 ppm is usually very small at the long echo time, but the presence of this peak is already indicative for this non-ketotic hyperglycemia. And to come back to just the discussion before, at 1.5 Tesla, myoinositol is really a pseudo singlet, so it's really overlapping with the glycine completely. At 3 Tesla, it becomes more like a doublet, so you might also distinguish them, and at 70 they are even more distinguished. But going to another echo time is also the solution in this case. To continue with some metabolic disorders, we also always screen children with developmental delay, especially language or speech delay, for creatine deficiency. There are 3 creatine deficiencies with variable creatine levels at baseline. We have 2 creatine synthesis disorders, GAMT and AGAT. Then the body doesn't synthesize any creatine at all. And you see that here in the spectra that there's no signal at 3, and of course also not at 3.9 ppm. There's also a creatine transporter defect. Here there's enough creatine produced by the liver, but the transport from the body to the brain is decreased. In this case, we see a low creatine level. And because this developmental delay, of course, it's one of the main questions of children to get an MRI. And then the creatine screening is only done within 1 minute. We just have 16 averages in the gray matter parietal cortex, and then within 1 minute you can at least exclude that this is the problem. It's faster than plasma or genetics. When we have a case with this creatine synthesis disorder, these children can be treated with oral creatine. And in fact, we had a child, a girl, who was diagnosed, and after 3 months of treatment, actually her creatine levels completely normalized. Unfortunately, afterwards, there was a slow decrease again due to limited therapy compliance. But here you see the increase in 4 different brain areas, and they are really up to normal levels for that age. Actually, more typical is that those patients have an increase in the creatine, but approximately 60% of normal levels is more common. One other disorder or metabolic disorder is a case of GLS hyperactivity. This has been described in 2019. And you see here a girl with extremely elevated glutamate and actually near absent glutamine, observed at the age of 2 and 3 years at 1.5 Tesla. And you can see here the glutamate here on left, glutamine here on right. Again, glutamine and glutamate in cortex and white matter. And you see both with single voxel steam and press, and also with CSI press, that the glutamate level is really high, especially here in the white matter. The glutamine level is very low. Of course, you will know that if something is absent, like in the creatine cases before, the Kramer-Rao bounds are high. If there's nothing, the uncertainty seems high. But of course, absence can also still mean something. And based on these results, there were done further clinical and genetic analysis in this case. And the child had actually an hyperactivity of GLS, which is the enzyme that converts glutamine into glutamate. It leads to an excess of glutamate in the brain, the cataract, so the lens is involved, and a severe developmental delay. 10 years later, when finally actually everything was solved, the girl also had a scanning at 70 Tesla, and then the high glutamate and the low glutamine were confirmed in this child. And you see it here, the fit of the glutamate, which is really high, and the glutamine, which is also nearly absent. Of course, at the age of 14 years, the 1.5 Tesla would really be more challenging, because then the brain has already changed so much that the very high quality at 1.5 Tesla is lost. I would like to continue with the predicting the effect of treatment, but actually I would rather go and continue with other stuff, because I think the methodology is more interesting for the majority in the audience. And I can refer you to those papers of the treatment of MLD and X-linked adrenoleukodystrophy. Because the question actually was, with this work of the last weeks for me, is which metabolites to include in your basis set. Historically, I mean, that's last century, I always made the homemade phantom with a solution of creatine, phosphocreatine, etc. And occasionally also succinate, pyruvate, this PG, of course, this propylene glycol, and polyols, of course, because you always need to input in your basis set if you observe something in your spectrum, which is not in the basis set. And then in case of those neonates, you get here the 48 average data sets, and you get a fit with my standard basis set, and it's, of course, very nice. But then, because I had to also adapt to S-laser and to another scanner again, I wanted to add metabolites, and I was using the Mars simulation package, which is very nice in my opinion, and because it's the option to really adapt to the vendor and the sequence. And when I included exactly the same metabolites using Mars compared to my own homemade basis set, I still get a very nice fit, of course, slightly smaller residuals, in fact, leading to a rather smaller increase of SNR. Remember, these are some spectra. But then Mars also gives other metabolites, such as ascorbate, serine, and others. So, of course, I also included those in the basis set and started to compare the effect of adding more metabolites. And when I add also ascorbate and serine, actually the residuals become even smaller. Of course, again, this is the sum spectrum. But when I also check the individual 48 individual spectra with those basis sets, I checked the effect of these basis sets, so the standard one with the ascorbate here in orange, with the serine, and with both of them, and what effect they have on the concentrations. And here for the major concentrations, for those minor or smaller metabolites, and of course also the Kramer-Rao bounds. And I'll show you already that the fits improve with using ascorbate and serine, and also both have a consistently low Kramer-Rao bounds, actually to my surprise. Serine even below 10%. So in an individual neonatal spectrum at 1.5 T with, done at only 2 minutes, I consistently observe this serine peak and actually also the ascorbate. Also, the Kramer-Rao bounds of glutamate and glutamine tend to decrease when adding these metabolites. But also for the creatine, it has an effect. When you add serine, the creatine slightly decreases. The glutathione is hugely influenced by the ascorbate, and also glucose is slightly influenced. And so the addition of the serine causes a decrease mainly of the phosphocreatine, as you can see here, because they really overlap or nearly overlap. And also the ascorbate causes decreases of the glutathione. But the metabolites are only moderately negatively correlated if you check that with the all individual scans. So both serine and ascorbate are observed with low Kramer-Rao lower bounds in individual spectra. And also the glutamate and glutamine cerebral B decrease when adding those data sets, those metabolites to the basis set. Of course, ask your special attention to the fact that I actually always use a very small bandwidth of the water suppression pills, smaller, much smaller than the default vendor values, because otherwise you also suppress your 4.0 and 4.2 ppm metabolites. And if you have a too strong suppression, you also suppress the second creatine peak, and of course also the serine. It can be that in the neonates, serine can be very high, simply because there's also developmental changes. I didn't investigate it fully yet, but also at 3T, the selection of the 68 high quality spectra, I also see a consistent detection of the ascorbate and the serine in the individual spectra. And you see here, again, the serine peaks, ascorbate, kind of a doublet, the glutathione, but also, and then this is another point, I will need to check the correlation with the alpha and the beta glucose, because they are really different. And if you put in the total glucose, it can be a problem, but I'm not sure yet. But then, while combining all those data, and I realized, okay, but I also have the patients with the creatine deficiencies. So when they don't have creatine, I'm going to look for the serine in those spectra. I didn't do that yet because that only came up last week. So which metabolites to include? Well, actually, to my own surprise, ascorbate and serine were consistently observed in the pediatric spectra, both at 1.5 T and at 3 T. Then the Mars package has the glucose, which is kind of a fixed combination of the alpha D-glucose and the beta D-glucose. When I add them both separately, the fit generally improves, but there's also competition, so the negative correlation between ascorbate and alpha glucose. So I'm not sure yet what is the truth here. So in future work, we also have patients with so-called vanishing white matter disease. And in this leukodystrophy, the glucose levels are very high. So really want to investigate whether I can detect glucose as a combined or glucose A and glucose B separately, and also what that does with the ascorbate. Also want to include beta-ine and the EA and the PE metabolites, which I haven't done yet. And just want to draw your attention that if the CRLB can be relatively large when concentrations are low. And in this case, the increased levels in the pathology are more reliable. But if you want to compare it with normal values, say from control subjects, then you might need to include those values even when the Kramer-Rauer bounds are higher than 20%, because you want to be able to establish a normal upper limit. So as a final remarks, I think I've shown that spectral quality can be excellent at 1.5 Tesla, also at 3 Tesla. But the most important thing, and that's actually also matters for 70, the underlying field homogeneity is the most important aspect of getting a nice spectrum. Of course, you need to know to use a proper basis set, preferably adapted to the vendor and the sequence. And I always told everybody, look at your spectra carefully, but actually now I'm quite surprised myself that I never looked at serine, for instance, or ascorbates, and I really looking forward to my future investigations here to see whether this is really correct. And also whether there's an age dependency. That's why I only see it in the children, and when they are, say, 8 or 10 years old, that it's gone, but I'm not sure yet. Of course, it might be that quality or low quality or spectra with a smaller or slightly lower quality may be possibly repaired by AI in the future, which would be very nice, of course. But remember that it will always require a training set with proper metabolites. If I don't put in serine or propylene glycol or succinate or pyruvate, then I will never get that out from a training. So thanks, this is not DCAO, of course. Just to have a thanks, the solid base of, say, my spectroscopy in vivo career has been in Jens Fram's group in the Max Planck Institute in Göttingen, where I also met Steve Provencher, who was there at that time. The body of the cow is really the radiology and the child neurology of Amsterdam UMC, Maya van der Knaap and Frederick Barkov, and of course many others. I think the colorful spots are definitely the students, the PhD students and the postdocs who make life really very nice. Sometimes the horns can be quite stubborn. I've been working on, I think, 4 different vendors, and I also learned a lot from them. And the cowbell, I love it because it really reminds me of holidays and cycling or hiking in the mountains. But it also stands here for the wake-up calls from the MRS community, because I think there's always progression in the field, which is very nice. So I thank you for that and for your attention.
Thank you very much. We have perhaps 1 or 2 minutes available for questions. We have somebody young who would like to ask a question.
No gray.
Yeah, I feel like I'm young, even if I'm not. When you give creatine to children who are creatine deficient, do they improve clinically as well as the signal going up in the smoke?
Yes, they improve clinically, but they don't become normal. But yeah, they get better.
Question at the back.
First of all, yeah, thank you very much for the nice presentation and illustrating the potential of MRS in pediatrics. And my question is regarding the propylene glycol is something new for me. I'm hearing first time. And does it producing specifically in the human brain of babies, or it's also found before in the adult human brain?
Oh, I think your question is whether if you give the medication of the phenobarbital to older people, whether you see it then as well, or to children. I think I never saw it before, and I think the main effect is that the half-life in adults, but also, of course, in somewhat older children, is much shorter. So the elimination, if you give it, you really need to scan, say, immediately to be able to see it. But if I would give it to an adult and I would put in, say, the same amount, so the number of grams per body weight as I would give to the neonate. And then if I would scan the adult, say half an hour later, I would definitely observe it. But I've never done it. But because you scan I mean, they get it a few times, and mainly the first time is a large bolus, and then a few smaller amounts. But because we scan them also quite short after the medication, and because the half-life is so very long simply because the liver and the kidney, which are usually eliminating this PG, they are not fully developed yet.
Okay, thank you. Because it close to 1.13, it appears at 1.13 ppm. It's also close to acetone like beta hydroxybutyrate and other producing inherently in the human body. So that's also my assumption, because it includes acetone bodies also.
I've been trying to use the beta hydroxybutyrate as well, but then it has a slightly different spectrum. But of course, you will always need to be aware that it can be you have other things than lactate at that position or near that position.
Yeah, well, maybe one more question. Quick question and a quick answer, please.
So I might have missed this, but so you showed a graph where you talk about changes in creatine with when you include, let's say, a sorbate or serine in your basis set.
Yeah.
And I was just wondering what the key takeaway was from that graph, because if you include those metabolites in your basis set and they have an overlapping chemical shift with major peaks, then of course they're going to find it in your, and it's going to change the concentration of your whatever metabolites it overlaps with. So I was just wondering what the point of it was, I guess, just of the graph.
Well, I have to check what happens with the Kramer-Rao bounds. I mean, you have for creatine, you have also the 3.0 ppm, of course. I mean, it's not, if you have only the 3.9 ppm, then it's very difficult. But you also have the 3.0 ppm, but it has an influence. And yeah, it's for me, it's quite important. If I change my basis set to that, all my, say, normal values will change. So I really have to think, is it worthwhile to put in serine? Because I mean, if creatine changes, and I not only use creatine for referencing, but I also use creatine for referencing, also the ratios will change slightly. I mean, it's minor, but
sure. I'm just curious. A lot of those like metabolites that we look at, like ascorbate and serine that you included afterwards, there is like large spectral overlap with other major peaks, and so I think shouldn't your basis set be more guided whether you expect to find other metabolites in the region rather than maybe a visible concentration from your output? Because isn't it kind of biased to do it to determine whether you include it based on whether the output is a significant concentration, considering that is a large variability in whether you actually find it, since it's hard to detect or hard to discern from your spectrum?
I have to get into that further, but I think the Kramer-Rao bounds kind of guide me towards including those towards including those metabolites. And if they are so low, I think we need to include it.
Okay, thank you.
Thank you very much.
Okay, and now I'll introduce our last speaker for the session. Dr. Vera Schrawin-Hinderling is from the Department of Imaging, Nutrition and Movement Sciences at the School of Nutrition and Translational Research and Metabolism, Faculty of Health at Medicine and Life Sciences at Maastricht University. She'll be talking about MRS applications in the liver and muscle.
Thank you. Good morning, everybody. And I would first like to thank the organizers, of course, for the invitation to this great conference. And also like to point out that at the presently I have a double affiliation. So next to working in Maastricht, I also work in Düsseldorf at the German Diabetes Center 2 days a week. I would like to talk about applications in liver and muscle, and specifically in the field of metabolic research. And I think I'm sure you're aware that metabolic disease is a big problem and actually still increasing problem due to the still increasing prevalence of obesity, and we have an aging population, and that makes things worse. I hope I can show you that there are some interesting applications of MR spectroscopy in this field. I like to look at metabolic health as a balance between substrate supply on the one hand, and here you see electron microscopy image of the muscle, in this case of lipid droplets that are stored inside the muscle, and on the other side of the balance, oxidative capacity, so the capacity to oxidize a substrate, and here we see a mitochondrion. And in the case of insulin resistance, fatty liver, type 2 diabetes, or other chronic metabolic disease, we see this disbalance. So there is too much substrate available and the oxidative capacity can't keep up. And interestingly, we can probe interesting parameters in that respect on both sides of the balance with MR spectroscopy. So on the substrate balance, we can use proton or carbon MR spectroscopy to quantify glycogen and lipids. And on the other side of the balance, mainly phosphorus MR spectroscopy to look at oxidative metabolism. And about 20 years ago, this research in metabolic diseases really got a boost with MR spectroscopy, because the hypothesis was formed that fatty acids in obesity are not only stored in adipose tissue, where most of the fatty acids are stored as triglycerides, but also in organs as so-called ectopic fats. And this can be measured with MR spectroscopy. And why is this interesting? And because it strongly correlates with insulin resistance. And insulin resistance is the first step in the development of diabetes. This has been shown multiple times, in this case in the muscle, but also in the liver and in the heart. It has been shown that the more fat that is stored, the less insulin responsive the tissue gets. Okay, and fortunately, in liver, heart, and muscle, we can determine fat quite easily with proton magnetic resonance spectroscopy. In pancreas, it's a bit more difficult because the anatomy is really difficult. And we do that by comparing the lipid region to the water region. And this is in the case of the liver, somebody with a fatty liver, non-alcoholic fatty liver disease with a fat percentage above 5%. We can clearly see these two peaks. And in a lean person, that's much more tricky, and the lipid peaks get really low, and we need good water suppression. And in that way, I think that was really a big step, especially in the liver, to be able to quantify this. So we can quantify the fat content. Yesterday, we also heard about the unsaturation index by Martin Krusok, and the abstract on IMCL by the group of Alison Slay about the saturation index in muscle. We took that a step further to actually quantify separately the saturated, the monounsaturated, and the polyunsaturated fatty acids in the liver. And we did that by just improving the spectral quality. And I realized that in brain, this is used a lot already, but actually in liver spectra, that's not used a lot, that you store the individual acquisitions. We optimized and frequency align and phase align each acquisition separately. We optimized water suppression, and especially also invested a lot of time into the fitting, because normally the fitting of these spectra is quite crude, but we also incorporated all prior knowledge on the couplings and some other things that I will show. The difficulty, so what we want to know in such a fatty acid, what we want to quantify to be able to have this quantification of saturated, polyunsaturated and monounsaturated fatty acids separately, is that we want to have this CH2 peak, C, which is next to a double bond. We want to be able to separate it from and quantify it, and also quantify this CH2 peak, which is in between conjugated double bonds, which is then representative of the polyunsaturated fatty acids. If we can separate those two separately, we can calculate these fractions. Now the problem, so here you see a spectrum at high resolution of an oil and the two resonances we're interested in. When we scan the same oil on a clinical scanner, and all the work that I show is done at 3T on a Philips clinical scanner, then you see that we have a problem that C and D are partially overlapping, and that's more difficult than to tear them apart. So the prior knowledge that we used here is that we know that the alpha carbonyl, so the D here is present once in every fatty acid, and the same holds true for the CH3 peaks. So you can actually relate it to each other. In that way, if you quantify the sum of these two peaks and the CH3 peak, you can get C and E alone. So from this, you can then calculate the different fractions, and we validated that in different vegetable oils. On the y-axis, you see what we measured on the clinical scanner, and on the x-axis, what comes from the high resolution analysis by actually 13C NMR. So the agreement was very good, and then we also applied this in patients. Either people without fatty liver, with fatty liver but no diabetes, and also in age and BMI matched type 2 diabetic patients, either with or without fatty liver. And in these people, we performed such an MR scan. I didn't talk about the fitting. Actually, we also optimized the fitting script in the way that all the line widths that are in there are broadened together, and that improves the fitting. So we performed this measurements. Then at the same time, people drank deuterated water, and then overnight the de novo lipogenesis was measured. So the deuterated water is then incorporated in newly formed fatty acids, and by taking then blood in the morning, you can extract VLDL particles that are coming from the liver, and in that way investigate how many fatty acids are then newly formed overnight. And we know that in fatty liver disease, it's not only a problem of taking up too much fatty acids and store them, but also that the new formation is also increased. So that's what was a measurement that was also performed. And then we probed insulin sensitivity, specifically of the muscle and also of the liver, by a two-step hyperinsulinemic euglycemic clamp. So there we infuse high doses of insulin and at the same time glucose to keep the glucose level constant. And the more glucose we have to infuse to keep it constant, the more insulin sensitive people are. And insulin normally does two things. It increases the uptake of glucose inside the muscle, but it also shuts down the output of glucose from the liver. And both things can get insulin resistant. And with that procedure, we can probe both. Okay, so when we then look at these three groups, we see what was expected on insulin sensitivity, that the control volunteers had the highest insulin sensitivity. So here insulin works fine, has a big effect on the liver, shutting down about 70% of the glucose output. You see that people with a fatty liver, this is less, and even less in the type 2 diabetic patients. When we then look at the fraction of saturated fatty acids, we see that clearly in the patient groups, this is increased. And also, when we look then at the correlation between the two parameters, we see a correlation of this insulin sensitivity of the liver, a negative correlation with saturated fatty acids, but not with total fat. And the red dots are the diabetic patients here. So interestingly, when we then related the parameters also to de novo lipogenesis, we didn't see a correlation with total fat, but when we look at saturated fatty acids, we see that there is a positive correlation with the rates of de novo lipogenesis. So it seems like the saturated fatty acids are a marker of de novo lipogenesis, which makes this parameter very interesting. And it's not so surprising that this is the case, because saturated fatty acids are the end product of newly formed fatty acids in the liver. And we see an opposite for monounsaturated and no correlation for the polyunsaturated fatty acids. So as a kind of clinical validation, we also wanted to include a group of patients where we knew that de novo lipogenesis is increased. And this is the case in glycogen storage disease type 1A. And indeed, when we scan these patients, we see that the fraction of saturated fatty acids in these patients is even further increased, even more than in the fatty liver and the diabetic patients. So I hope that I could convince you that looking at the kind of the distribution of fatty acids in the liver really has some added physiological value. And we do that in just by scanning carefully, doing the analysis carefully. Of course, you can also use editing, and this is a work by Pandi Ferraya that he presented at the ISMRM last year. You can also use editing to address this problem, and this can be especially helpful when people have a very low fat content. And here you see the results in oil, and here in a patient, and you see that this C group is coupled. So by using editing, we can refocus this, and then when this is subtracted, you're left with the C group alone. So again, this is a way to differentiate between this C and D resonance, as explained earlier, and it also works in vivo. So next, so another substrate, of course, is the glycogen. I don't want to go into detail here. Just want to mention that, of course, it's an important parameter to measure, and we normally do that just by direct 13C spectroscopy. An FID with a 90-degree pulse that is calibrated to give mainly signal from the liver. And when you don't use decoupling, the glycogen, which is here a very small peak, when you zoom in, it's a doublet. And we then do the analysis by aligning the two conditions that we want to compare, and then look at the difference to minimize the influence of different phasing of the spectra. This is a small proof of concept experiment with 3 people fasting overnight. So glycogen loading in the evening by just eating a lot of carbohydrates, and then fasting overnight to validate that we see what we are expected to see, that glycogen is then decreased. So this is another parameter that we use in our metabolic studies. So I was talking about the substrate side of the balance. If we then go to the oxidative capacity side, it's mainly phosphorus MRS that is interesting. And you can do just direct phosphorus MRS on the liver and on the heart. And on the liver, it's actually interesting to see that when you do this quantification absolutely, so by phantom replacement measurements, you see that this is sensitive markers in diabetes, which is shown here actually. So the absolute concentration of ATP is decreased in diabetic patients when you compare it to age-matched and BMI-matched controls. And regarding the heart, it's especially interesting to look at the PCR-ATP ratio as a kind of energy status. And the classical work by the group of Stefan Neubauer showed that this has also prognostic value in heart failure. So the lower the PCR-ATP ratio, the worse the prognosis. So in the heart and the liver, we can basically just look at the phosphorus spectrum. In the muscle, the spectrum really doesn't change much, even in metabolic disease. So when you just do a resting spectrum, it doesn't tell you much. But what you can do there is challenging the system. So have the the muscle exercise. That was also what Martin showed yesterday. And I want to show some data from us on that. So this can be done. We do these measurements on the upper leg. The nice thing with that is that you can do knee extension exercise with such an ergometer in the scanner, and there the whole of the quadriceps muscle is actually activated. And you can place a small surface coil on the vastus lateralis. That's where we also take the biopsy, so we can directly compare then the measurement to invasive methods. We give patients a sound to which they have to move. I mean, we target the depletion of 30 to 50%. It shouldn't be too much of depletion, because then you get acidification, which slows down the PCR recovery. And you don't want that, because the PCR recovery rate is really what you are interested here. Because here you see the time course then of phosphocreatine. So first it's stable in the resting state. When people start exercising, it decreases. Normally it gets into a steady state. In this case, not much. And when people stop exercising, you see this rapid resynthesis of phosphocreatine. And we know that this is fueled almost purely by oxidative metabolism. So the half time of this recovery tells you something about how well the mitochondria function. And one way to increase your oxidative capacity is by physical exercise. We showed that in the past. Other people also showed that any kind of exercise program improves oxidative capacity, so shortens the half time of PCR recovery. We did lately also a study with high intensity and exercise, shorter but more intense exercise sessions, and we actually see the same. So this was 12 weeks of training with pre and post measurements, and there we see that general fitness by looking at whole body uptake, maximal uptake of oxygen improves, the maximal performance improves, and also this in this case it's the rate constant that is given improves. So the PCR recovery gets quicker. And in many chronic metabolic diseases, you see this slowing of PCR recovery. But what I would like to show also here today is that I think it's also not only interesting to look at this off kinetics. So when you have this time course of rest and then doing exercise and then stopping exercise, that not only this recovery is interesting, but also this first part, which we can call the on-kinetics. So the sudden increase in ATP demand at the start of exercise, how does the muscle respond to that? And why do I think it's interesting? When we do rather low intensity exercise, it's mostly oxidative metabolism that is fueling the ATP demand. So when we look at how quickly we get into a steady state, it means how quickly we're not dependent anymore on PCR. It shows you how quickly actually the mitochondria are activated. So short on kinetics of PCR show you a good mitochondrial activation. And we investigated that across the whole metabolic spectrum. So from highly trained athletes to they were lean and young, untrained, lean young people, to obese, somewhat elderly people, and type 2 diabetic patients. These two groups were age and BMI matched, and these two groups also. We characterized them in insulin sensitivity, also the PCR recovery. But when we look at the on kinetics, we see that the type 2 diabetic patients, so the most metabolically ill people, have the slowest on kinetics, so the slowest mitochondrial activation, then the obese, then the lean untrained, and the trained, exactly as we would expect from this spectrum of metabolic health. We also, during the steady state, quantified ADP concentrations, and we actually saw this same pattern, that the type 2 diabetic patients had the highest ADP concentrations, yet the slowest mitochondrial activation. So this may actually reflect an insensitivity of the mitochondria to ADP in activating metabolism. So we have these two sides of the balance. In between, I think it's also interesting to look at some intermediates, some metabolites, and a lot of them need to be addressed by editing because they are not normally not visible in the spectrum. And as an example, I would like to show some data on acetylcarnitine. Normally, we use short echoes to investigate the muscle by proton MRS. But when we use longer echo times, you see that the fats are relatively suppressed. And this small peak here, which is acetylcarnitine, not really visible, then becomes visible. And this can be, so this is actually a T2 editing. This can be improved by also using the T1 editing. The T1 of acetylcarnitine is very low, so we use a specific sequence to address this. I think I don't go into detail here due to time, so in lean subjects, the long echo times is sufficient. In obese subjects where you really have a lot of fat, you should also use the T1 editing on top of it. When we investigated this in the same 4 groups, we also see that acetylcarnitine concentrations are highest in the most healthy people. And we see a positive correlation with insulin sensitivity across these 4 groups. So acetylcarnitine, what is it? It's when we have acetyl-CoA in the mitochondria, it can be conjugated to carnitine and by an enzyme called CRAT, and then it can actually leave the mitochondria because acetyl-CoA is not able to pass the membranes. But acetyl-CoA has some important signaling properties, so it inhibits PDH and thereby the input of glycolysis into the TCA cycle, and which is not beneficial for diabetic patients. So we think that actually the formation of acetylcarnitine is beneficial because it buffers acetyl-CoA concentrations in these people. And you also see that from some animal data, for example, from CRAT knockouts, animals, they are in glucose intolerant, and so it may well be that this capacity to form acetylcarnitine is an important factor. So in which situation acetylcarnitine is increased? This is when the metabolic flux is increased, for example, during exercise. So we investigated acetylcarnitine concentration at baseline in the resting state in 3 groups. There were age and BMI matched, normal glucose tolerant, impaired glucose tolerance, and type 2 diabetic patients. So impaired glucose tolerance is kind of a pre-stage, if you want, of type 2 diabetes. We see this slight decrease in the more metabolically challenged people. When we look at the concentrations after exercise, so they cycled for 30 minutes at quite high intensity, 70% of the maximal power output. We see that acetylcarnitine in all groups is increased, but you see that the differences between the groups become more clear and actually become significant. So we think that acetylcarnitine in the resting state is interesting to look at, but I think the parameter for metabolic health may be more sensitive when, again, you challenge the system and increase these concentrations because it's about the capacity to form that metabolite. Okay, so I hope I could give you an idea why I think it's really interesting to apply these MR methods in the field of metabolic research. And I would like to thank, of course, all the team. A lot of work that I showed was performed by Pandi Verraya and by Julian Mevenkamp, who are both here, and like to thank the team in Düsseldorf and Maastricht and my collaborators, the funding, of course, and I would like to thank you for your attention, and maybe I have some questions. Okay.
Are there any questions? Okay. Well, yeah, as you're, cool. Oh, well, this is probably a quite simple question, but if you were to add one more group to the 4 that you showed us, so one more experimental group, so let's say an overweight active group that's similarly active as the non-overweight individuals, do you think that you would find a difference, or would that overweight active group be similar to any other group in your study?
I think, yeah, we interpret it as like metabolic health. So in that sense, I do think, I mean, these groups, they differ on more parameters than just one. So the age and indeed the BMI are an issue. And if you would like to really see what is the difference, we would have to do these experiments as you suggest and match them on anything else than one differing parameter. But what we generally see, of course, in diabetic patients is that they are older, they're more overweight and more inactive. So,
thank you.
Thanks, very interesting talk. I love seeing all the muscle and liver stuff. So I noticed you had a measurement of ADP on one of your slides. Can you tell me how you did that?
ADP?
ADP, yeah.
Yeah, it was just calculated from ATP, PI, PCR, and then assuming a constant for Michael is mentioned.
Yeah, okay,
yeah.
Yeah, thanks.
Okay, thank you. That's
Yeah, it's okay. So thank you for the introduction. I'm going to introduce a new spectrality at ultra-high field for 2Hg detecting. So thanks to the previous talk, they already mentioned about why the 2Hg is an important biomarker for IDH-mutated glioma. And because the 2Hg is normally has a low concentration and also overlap with other metabolites. So it's not easy to detect using normal MRS. And one common way to detect it is to do spectral editing, and a common way is to use MEC editing. And because it's a low concentration, so people will think that we can gain. Oh, the next slide. That's it. Perfect. Sorry. So because it's low concentration, so we will like to go higher magnetic field to get higher SNR. That's the main reason we would like to go. But the question is there really an advantage to diagnosing IDH status using MRS or I at 70? Because beside of the gain of SNR, we also have the price to pay. Like we have increased chemical shift displacement artifacts. We have increased SAR, increased RP power, increased B0 and P1 homogeneities. The CSDA is inversely proportional to the bandwidth of I pulse. And the SAR, in contrast, is proportional to the bandwidth of the pulse, and the RP power is the square root of the bandwidth. So in order to cope with challenges, we propose a new spectral editing. It has 2 acquisitions, acquisition 1 and acquisition 2. The key point is we use this chemical shift selective adiabatic pulse to do both refocusing and editing at the same time. Here I show the pulse bandwidth for acquisition 1, we call editing full. It covers from 1.6 ppm to 4.2 ppm. And the second acquisition editing partial, it has a narrow bandwidth, which covers from 2.7 to 4.2 ppm. So this is the corresponding phantom measurements. The editing full, you can see here, the blue one, and the orange one is editing partial. Then we do the subtraction, we get the editing difference. It is consistent with the simulation result, as you can see here, the 2Hg. For this editing scheme, We can also have the co-edited metabolites for GABA and GLX, because I say we use this chemical shift selective pulse. So the CSDA is decoupled with the bandwidth of the RF pulse. Therefore, we can use the narrow bandwidth of the pulse. We can lower the SAR and lower the RF peak power. This editing scheme is integrated into the FC sequence, and the TR is about 1.5 seconds. The total measurement time is 9 minutes for whole brain measurement. One advantage to use this 2-pi CSAP is that we can get excellent water lipid suppression at 0 SAR cost. As you can see here, if the pulse bandwidth cover the water, then you only see the water signal. You don't see the metabolite signal. If we narrow the bandwidth that do not include the water, then there's no water signal. And you can see this is the noise-like water map, which is nearly perfect. So we can get this excellent water suppression, more than 1,000 factors. The second is we have no implant CSDA for this slow FC. As you can see here is the metabolites integration map in the phantom, the NAA, creatine, GX, and the reference water. If we over the NAA map over by the water, we can correct the B1 plus and minus. So we get a very homogeneous map, and you don't see the chemical shift displacement artifact implant. In contrast, you do see this clearly CSDA using semi-laser, for example, the NAA, which is designed to be the red area, but it shifts to the left and bottom to the white area. The other advantage is we are B0, B1 homogeneities. No, robust, sorry. We compare with this mega pulses for editing, which is a single Gaussian pulse, and with our hyperbolic second pulse. We do the simulation. In the y-axis is the chemical shift, and here is the B1. So in this area is the plus and minus 0.2 ppm, and also the plus and minus 60% for the B1. You can see we are homogeneous in this area, but it is not for mega type of pulse. Then we come to the simulation for 2Hg, also compare with slow and mega. Again, in this area, within 0.2 ppm and plus minus 60% of B1. The blue one is the slow editing. We are robust to these homogeneities, but mega does not. Then we come to our in vivo cases. There are two cases, and this one is IDH wild type. This one is IDH mutant. Orange one here is the tumor, and the blue is the control healthy tissue. You can see at 4 ppm, you don't see a signal difference, which indicates there's no 2Hg. And here, for this IDH mutant, we detect the 2Hg in the tumor parts. And here's the spectra for the slow full and slow part data sets. You can also see the other metabolite change, the NAA, creatine, also myoinositol. Then we furthermore compare with slow FC with mega single voxel and mega CSI at 70. There are 3 patients. They are all IDH mutated, and they are all successfully detected by slow FC. You can see here, here. But they are all failed for mega CSI. For single voxel, it failed for this one. You can see there's no co-edit GABA, co-edit GLX, and also artifact around 4 ppm. You can also see some artifact or strong artifacts in this mega CSI or single voxel. And the measurement time is 9 for slow and 5 to 6 minutes for single voxel and 8 minutes to single CSI. Then in total, we have included 12 patients in our study. 3 of them are IDH wild type. So what we did is we perform our measurements slow FC on 7 Tesla and mega CSI at both 3T and 7T before the surgery. Then we made our prediction based on each result. And after the surgery, we confirm our prediction with the pathological results. And the highest accuracy is our slow FC, 91.7%. And the lowest is the mega single voxel as 3 Tesla, but it increased a lot, get much better at 70. While for CSI, you don't see very much improvement. Actually, it's a little bit decrease, maybe because the B0, B1 homogeneities and the CSDA. Then beyond the 2HG, we realized in this ISMRM that there are another interesting metabolites. Here is the new classification of glioma since 2021. And now the classification is easy. So if it is IDH mutated, it's called astrocytoma. If it is IDH mutated with 1p19q codeletion, it's called oligodendroma. If none of them, it's called glioblastoma. So this 1p19q codeletion also plays an important role in this classification. And previous study from Brazil, she showed that there is an important strong relationship with this cystathionine and the codeletion of 1p19q. So since then, we start to look at also 2HG and the cystathionine from after the ISMM. This is our first cases in our patient. We detect both 2HG and cystathionine. And we made our report to our radiologist, and afterwards it confirmed we were correct. So this is the words from our radiologist. He said, to put how great this finding in tumor wall, we made 10 minutes scan and predict correctly, while it needs 2 weeks for this pathology result to confirm. So he thinks there's a much more potential in it. So comes to the short summary. We propose a new spectral editing, slow editing for whole brain measurements in 10 minutes. It has those advantages to robust to B0, B1 homogeneities, reduce the CSDA in the Z direction, but no CSDA in plan, and reduce SAR, reduce RF power. We have further water lipid suppression without zero SAR, with zero SAR cost, and no fallback aliasing artifact because we also dephase the signal beyond the bandwidth. So that's also an important fact for fast MRSI. We have the high accuracy in 91.7% in predicting. We also can detect the co-added cystathionine as 2.72 and 3.85 ppm. And if you are interested in this technique, you can look at this published paper this year. Yeah, that's pretty much of it. And I thank to my team and thanks for your listening.
Thank you very much, Godong. There must be comments on that great talk.
Yeah, I agree. It was a great talk, and I particularly like this rigorous analysis of like robustness against B0 and B1. I wonder if you could comment on like what happens beyond the 0.2 ppm. So I guess like you have partial editing. You probably you're looking for existence or absence of 2HG. Let's say you're 0.3, 0.4 ppm away. You probably would still be able to see this if the effect size is reasonably high. So, I wonder if there's at the end of the day, a tuning curve that your method is, you can say it's not only walking up to 0.2 ppm, but maybe a lot further.
Yeah.
Right?
So let's say it has 2 sides. If you shift to the left side, which means the 4 ppm actually shift to 3.6 ppm. That works pretty good. And if it shifts to 4.4 ppm, it will be partially dephased. but this can be designed by the pulse. We only provide an example for this pulse, but you can design it to be wider, but also realize that there's a compensation that if you make your pulse wider, then the water signal suppression might be a little bit worse. That's the compensation. But if you go to even higher magnetic field, this could be better.
So I fully agree. I think that's very nice. I was not referring to like redesigning the pulse.
Yes.
I was if you have, let's say, B0 variations throughout the brain, you gotta use a pulse that works everywhere. I was more wondering basically like how well it still works even if you're outside, the exact frequency position that you're ideally assuming.
Yeah. And yeah, if I understand your question, let's say we can plot a curve that's if the ppm shifts from 0.2 ppm away to the 0.4 ppm, and like I mentioned, if it shifts in the other side, let's say go to the 2 ppm side, I would expect the performance is still robust. If it shifts to the water side, the performance will decrease after it exceeds the 0.2 ppm, which is what we designed. That's the answer.
Last question.
Yeah, this is really great work, I think. Congratulations.
Thank you.
I have a question. We know from, megapress single voxel spectroscopy, how critical it is to, compensate post-acquisition for any phase and frequency instabilities. So when you're subtracting the on and the off scans, that you don't have artifactual subtraction artifacts. And I'm just wondering, did you, in your comparison to these other editing techniques, I'm wondering what phase and frequency correction you used actually for all the techniques, including for the slow EPSI, because that could strongly influence the results, I think.
Yeah. So for the mega editing, we followed the protocol we used before. So because it occurred interleavely, we just to subtract the signal, let's say the mega on and mega off subtracted, then we do the phase correction and frequency correction. That's for mega. And for ours, because now our version is not interleavely, we actually acquire first acquisition for 4.5 minutes, and the second one. So for each acquisition, we'll do the phase and frequency correction in advance, then we do the subtraction. Yeah.
Now we move on to the last talk of the session. Probing diffusion of water and metabolites to access white matter microstructure in Duchenne muscular dystrophy by Dr. Govard.
Yes. Thank you very much for this nice introduction and the opportunity to present our research. My name is Roseanne, and I would like to share with you our research on probing diffusion of water and metabolites to assess white matter microstructure in Duchenne muscular dystrophy, a two-center study, which would be like a more clinical presentation. So first, a little bit of background about Duchenne muscular dystrophy, DMD. It's an X-linked recessive neuromuscular disorder. So that means it's like carried by the mother, and mostly male are affected. And it's caused by the mutation in the dystrophin gene, like the DMD gene. These symptoms include like progressive muscle degeneration, so muscle impairment, muscle atrophy, but also learning and behavioral problems. The prognosis is that they had the onset of the disease between like 2 and 6 years old. They were wheelchair bound around the age of 80 or 14, and a premature death around the age of 20 to 40 years old. So if we look more into the gene, we know there is like a mutation, but there are multiple dystrophin proteins within the brain. And what can happen during the disease is not one, but also multiple dystrophins will be missing, and depends on the DMD gene mutation on which axon. So we know if there's a mutation, there's like involvement in the muscle, like due to the muscle impairment, but also in the brain. And it's really depending on where the mutation is along the DMD gene, what is affected or more severely affected. So if we zoom more into the brain and we look at the dystrophin expression within the brain, we see like in the neurons that there is the GABAergic synapses, that there is dystrophin involved. And also if we look at the astrocytes, we can see that at the aquaporin 4, there is a water channel, there is like a dystrophin involved as well. So it's associated with those two things, neuronal and also in the astrocytes. So what we know from previous MRI studies, we know that their temporal muscle atrophy is in a more circular shaped head, as you can see on the right side for the DMD patient and the left side on the healthy control. There is a smaller total brain volume, but also the gray matter volume is smaller. They have a lower perfusion. And what's important to mention that this perhaps like through hood brain. So there's no clear like localized effect. Then if we look at diffusion tensor imaging and the previous spectroscopy studies, we saw like a similar white matter volume, but we did saw a different white matter microstructure. And also this was like spearhead through the brain, so no clear localized effect. And what we found in previous MRI study, there was a preserved metabolite ratio, so we didn't find any difference in there as well. So here on the left side, you see like the structural scans, and on the right side, you see the DTI scan with the frictional anisotropy and the mean diffusivity, which is like higher in DMD patients than it is in controls. So what we want to know is like more specific what's going on. And the problem with DTI is that water is like not specific. It's as well extras intracellular. And there's free diffusion of water. If we look at diffusion weighted MRS, it measured like diffusion properties, so the metabolites, and it's cell and compartment specific information. And we could also measure like the concentration of the main metabolites from the non-diffused spectrum. So if we place like a volume of interest and we zoom more into the brain, we can look like extracellular space to the water, and we can look like intracellular as well to the water and the brain metabolites. So we were specific interested in the creatine amount to look at like as well the glial cells as the neurons, as well specific to the gliocytes with the total amount of choline, and specific to the neurons for the total amount of NAA. So we thought like the diffusion-weighted MRS is a unique method to probe the intracellular space of neurons and glial cells. So we have to get more information of what especially is going on within those cells. So the aim of our study was to investigate if altered white matter microstructure in DMD is due to an intra or extracellular microstructural change using DWS and diffusion tensor imaging. And if there is like an altered intracellular microstructural change, what are the main cell types involved? So we had a two-site study, including Leiden from the Netherlands and Newcastle from the UK. And we had a total of 20 DMD patients and total of 10 healthy controls, and they were age matched and sex matched because they're all like males. So there was not really a difference between like the UK group and the Dutch group. And both sides had the 3T Philips scanner with an 8-channel head coil. So they're identical scanners, so we can like use the same sequence for both sides. And we placed a volume of interest in the left parietal white matter. And we choose like this particular volume because we saw on the mean diffusivity on the DTI scans that there was something going on. So we thought we have the main part like of the mainly like white matter, a small part of gray matter. So we thought we should, if we could measure something, it should be within this volume. And here you see like other details of our DWS data and also for the DTI sequence. So we had one anatomical, the 3T1 scan for the volume fractions, so we could like clearly distinguish between the cerebral spinal fluid, the white matter, and the gray matter within the volume of interest using FSL. And the DWS data was corrected for like eddy currents, phase drifts, individual frequency. We quantified the total NAA, the creatine, and the choline, as well as the ratios from the fitted non-diffused weighted spectrum as the ADC, like for the total amount. And we had like the spectra were accepted if they have like the limits like stated below. For the DTI scan, the same. So they have to like the imagings were corrected, and you have to have the certain quality control to pass. They were co-registered as well with the T1 as the DWS scan, and we calculated the mean diffusivity, the radial diffusivity, and the axial diffusivity of water within the specific like volume of interest, and we used Explore DTI for that. So here again, a quantification for the DWS data. So you see here like the volume of interest replaced within the brain, and you see like an example of the spectra we expected. And here you see example of two spectra like we gained from a healthy control as well as from the DMD patient. So if we look at the results, we saw like a similar metabolite ratio in as well DMD as the healthy controls. However, we see like it's more widespread in the DMD patients. We did not saw like any significant difference between those two groups. Also, if we look at the, there was a similar metabolite ADC between like the DMD and the healthy controls. So like it's kind of different that we expected. And if we look at the diffusivity data, it was higher in the DMD patients compared to the healthy controls as what we were found like in previous research. So, and they were all like the mean diffusivity, the axial and the radial diffusivity were all like significant difference and higher within the DMD group compared to the healthy controls. So for the discussion part, we saw that the metabolite ratios were preserved, and that was like in agreement with previous research, but different than we had expected, like with the placement of this voxel and the using of diffusion weighted like MRS. Also the mean ADC for all three metabolites were also comparable between the DMD and the healthy controls patients, and known like from the association of the dystrophin protein within the brain. Yeah, it's unfortunate that we didn't find anything. And in the same volume of interest, the DMD patients did show increased water diffusivity, as was shown before. So in conclusion, we saw like we can maybe conclude that all the white matter microstructure is likely due to extracellular rather than the intracellular, so the neuro and the glial fiber changes. However, we have like a small sample size, and that's what I mentioned before, like the mutation along the dystrophin gene can be different like for all kind of patients. So maybe if you look like more specific in what mutation they have, you can actually find a difference, but still it's a rare disease, so it's hard to include more patients. I would like to thank all participants and their families for like joining this study, and all my colleagues from Leiden and Newcastle who really helped and did all the work. So thanks for your attention.
Hi. So this might be a simple question, but since you're looking at white matter, is there a reason you didn't consider or didn't use myoinositol?
Sorry?
Is there a reason you didn't use myoinositol in the study, especially since you're looking at the white matter?
Actually, because we did know like I'm not sure if like really answering your question, but we did know like the involvement of the dystrophin like within the neuronal and the glial parts. We looked like just, yeah.
conditions were such that even if B equals 0, we could at the time sterically underline
For the online people, -DOL was not detectable at that echo time. Other questions, comments? Well, we're on time. Nothing from the web. So actually, we deserve lunch. Thank you, everybody. Thank you for presentation. See you after lunch again.
Yes, it's time to give me your cow challenge.
You hear me? Perfect. So we would like to welcome you for the last session, which is called, oh, where's the name? The last session, which is called Emerging Techniques, X Nuclei and High Field. And we would like to start with a presentation about the Deuterium MRSI given by Janine Prompers from the Department of Radiology from University of Medical Center of Utrecht. The stage is yours.
Thank you very much. And I would also like to express my gratitude to the organizing committee for giving me the opportunity to contribute to this great workshop. So deuterium, what is deuterium? It's an isotope of hydrogen, and the nucleus contains a proton and a neutron. So it's twice as heavy than the more common proton. And the natural abundance is very low, only 0.01%. And because of this low natural abundance, it's very popular as a tracer. And deuterium has actually been used as a tracer already for many decades in biomedical research. This morning, we saw an example presented by Vera, where heavy water was used to measure lipogenesis, but it has also been used to determine, for example, cell proliferation. So what is done here is that people are labeled with deuterated water or heavy water for sometimes very extended periods of time. And then plasma samples are taken. And what is done is that the deuterium enrichment in the DNA is determined by mass spectrometry. And this gives an indication of cell proliferation because the deuterium is built in the newly synthesized DNA. Now, because deuterium has been used already for such a long time, so not in combination with MR, but with other approaches, the biological effects and toxicity are also very well known. And for body deuterium water or body water deuterium enrichments up to 2%, there's no side effects reported. If you go a little bit higher, towards 3%, then subjects can become dizzy. This is, I have a low battery on my screen. Is that an issue? It's not plugged in anymore, I think. Oh, maybe it's loose. Or... No, not charging.
Okay, well, they're trying to fix it. We were told before to mention that the microphone in the middle has been fixed. They've attached some additional stuffs to it. And we would like to ask all the speakers to not physically touch the microphone to make sure that it keeps working and it does not fall apart. Thank you.
Full screen. Okay, we're back on track. Yeah, so
I was saying that if you go a little bit higher with the deuterium water enrichment, then people may become dizzy. This is just a temporary effect, and it's caused by a change in the specific gravity of the vestibular fluid. So that's the fluid in the inner ear. If you go even higher, 10 to 15%, then potentially harmful side effects may occur, like hypothermia, hypoglycemia, or any changes in the ECG. And if you go even higher, so 30 to 40%, it may even lead to death. So this sounds all very disturbing, right? But I want to reassure you that we use labelings that are much lower than those toxic amounts. So side effects, except for dizziness, maybe are not an issue for our applications. Now, deuterium also has a spin 1, in fact. So it's a quadrupole. So we can detect it with MR. The gyromagnetic ratio is 6.5 times lower than for proton. And that means that at 7 Tesla, the frequency for deuterium is 45.7 megahertz, so a lot lower than for proton. And because the proton and deuterium frequencies are so far apart, in a proton experiment, you wouldn't pick up the deuterium signal. And this has been used in the application of deuterated water as a contrast agent for perfusion MRI, so where proton is detected. And this idea was already proposed by Sir Peter Mansfield in the early 1980s. So here you see an example of the brain proton signal at baseline. Then this is during administration of deuterated water. And you see that the signal becomes lower, and that is because part of the protonated water is replaced by deuterated water. And if you subtract the images before and after D2O administration, you get these maps, and the higher the color, the higher the perfusion. Now, because we can also detect deuterium directly, deuterated water can also be used as a perfusion tracer itself. And this is an example in a mouse tumor model. The tumor is where the white line is, and this is the baseline scan, so you cannot really see some deuterium signal. But during infusion of the D2O, you see the signal increase, and these 3 time points are after infusion. And from these experiments, you can determine maps of perfusion rate and intravascular volume fraction. Now, in this workshop, most of us are here for measuring metabolism. So that is where deuterium can also be used for. In this case, dynamic deuterium MR spectroscopy is performed. And this is quite an old example. This is in bacteria cells, and these bacteria have the capability to produce bioethanol. So what was done is that deuterated glucose was added to these bacteria, glucose labeled at the 1 position. So very early on, you see here the deuterated glucose signal, the alpha and beta anomers. And then if you follow this during time, you see here the bioethanol signal coming up. More recently, this was also done in the brain of a rat. And in this case, deuterated glucose was used at was labeled at the 6th position. So then you have the advantage that you have 2 deuterons. This is a work from the group from Wei Chen. And here you see a baseline spectrum. So before administration of deuterated glucose. So this is the natural abundance deuterated water signal, which is around 10 millimolar and which can easily be picked up. So after infusion of the deuterated glucose, you see more signals coming up. So the glucose signal itself, but also a signal from glutamate and glutamine combined. This is term TLX, and a signal from lactate. And this is then also followed over time. Now, the nice thing is that we can very easily translate this to human experiments, and that is mainly because we can use oral administration of deuterated glucose. And this is an example of a spectrum, deuterium spectrum from the human brain, collected at 7 Tesla, about 15 minutes after the intake of 60 grams of deuterated glucose. So you see here the deuterated water signal, deuterated glucose, and the GLX. And so why do we see these signals? Well, if you look at brain metabolism, then glucose is taken up by the brain cells. This goes into the glycolytic pathway. So pyruvate is produced, which is in exchange with lactate. In healthy brain, there's not that much lactate produced. Most of it will enter the TCA cycle. And glutamate and glutamine are then produced at sufficiently high concentrations that we can detect them in the deuterium spectrum. Now let's look at the relaxation properties of deuterium. And this is work from the Yale group. And they determined T1 and T2 relaxation times in vivo at different field strengths for deuterated water and also deuterated metabolites. And you can see that the T1 of deuterated water in vivo is around 350 milliseconds. So that's quite short. And for the metabolites, it's even shorter. And this is a big advantage because due to the short T1s, we can do very rapid signal averaging. The downside is then, of course, that the T2s are also short. And for deuterated water, it's about 20 to 25 milliseconds, not really dependent on the field strength again. And this means that, of course, we have broad lines due to the short T2s. But this is not really a serious problem because the spectra are relatively sparse, as you have seen on previous slides. It's actually also an advantage because it makes our experiments rather immune to B0 inhomogeneities. So the quality of your shim is not that important. So you don't have to spend like a lot of time on shimming before you can start your experiments. If we compare deuterium with carbon-13, because of course carbon-13 can also be used to probe the same metabolic pathways, then there's several gains when we talk about sensitivity. And the main gain comes actually from the short T1 of deuterium. It's almost a factor 10 lower than for carbon-13. So due to the more rapid averaging for deuterium, we can gain a lot in sensitivity. There's also some other factors. And the most important loss is due to the lower gamma of deuterium compared to carbon-13. But overall, then there's still a fourfold gain in sensitivity. And this is without counting in coil contribution. So probably it's even still a little bit higher. And because of this relatively higher sensitivity of deuterium compared to carbon-13, we can do spatially resolved measurements for deuterium, whereas for carbon-13 at thermal polarization, this is not really possible. So the most common approach for deuterium is then to do very simple pulse and acquire MRSI experiments or FID MRSI experiments, usually with phase encoding in 3 directions. And because of the low natural abundant water signal and the low natural abundant lipid signal, there's no need for water and lipid suppression. So the acquisition scheme is really, really simple. So this was proposed by Henk de Vijter and Robin de Graaf in this seminal paper, which really spurred the interest in deuterium metabolic imaging, that's how they termed it, in many labs over the world. And so here you see an example of a DMI data set. So you have deuterium spectra for all these voxels. And if you then would plot the amplitude of, for example, the glucose signal in a color map, you get these this glucose metabolic map, and you can do the same for GLX. Now, this is a healthy subject. If you would make these metabolic maps in a patient with a brain tumor, and in this case, the lactate over GLX ratio was mapped, you see a very clear contrast in the tumor. And this is due to the Warburg effect. So in the tumor, there's very high lactate production and very little GLX production, whereas in the healthy brain, it's the other way around. So this leads to a super high contrast. And this is a big advantage of DMI compared to PET, because with PET, we only look at glucose uptake. And in certain tissues, like the brain, glucose uptake is also very high. So then the contrast between the tumor and the healthy tissue is not as big. So this has also been used in the group of Kevin Brindle to look at treatment effects of tumors. And so what you see here is that they used a tumor-bearing mouse model, and they also used deuterated glucose. And here you see the lactate over water ratio before and after treatment. And this is the lactate over glucose ratio before and after treatment. So you see a clear decrease. And this is the color map of the glycolytic flux before and after treatment. So this decrease in glycolytic activity indicates that the tumor was actually working. In the same group by Kevin Brindle, they also took another approach where they used, instead of deuterated glucose, they used deuterated fumarate, again in the tumor-bearing mouse model. And if you look then at the signals before treatment, you actually only pick up the fumarate signal in the tumor and no malate signal. Whereas after treatment, also a malate signal comes up, and that indicates a loss of membrane integrity or necrosis. So again, this would indicate responsiveness to treatment. Together with the Yale group, we looked at the magnetic field dependence of DMI. So here you see the relative SNR determined in the postmortem rat brain at different field strengths. And you see this supralinear relationship. We also look at this in the human brain at 4 Tesla and 7 Tesla. And these spectra here are scaled to the same noise level. So you see the clear gain at 7 Tesla. And we actually determined that the sensitivity scales would be 0 to the factor 1.65. Meaning that if you do a DMI scan at 7 Tesla, you have a 4-fold gain in signal as compared to 3 Tesla. So it really pays off to go to ultra high field for DMI. This increased sensitivity can be used to increase your spatial resolution. So that's what we demonstrated here. So again, 4 Tesla here on the left, 7 Tesla on the right. This is with 8 milliliter voxels in the brain. You see this better spectral dispersion at 7 Tesla. But at 7 Tesla, we could go down to 1 milliliter voxels, whereas at 4 Tesla, then, yeah, you cannot really recognize the metabolic signals anymore. This was taken one step further in the group of Anke Henning, where they went to 9.4 Tesla for DMI. And they actually did dynamic DMI scans with a nominal spatial resolution of 3 milliliters and a temporal resolution of 10 minutes. And here you see the metabolic maps for water, glucose, and GLX for 3 different views and for a whole series of different time points, where you can really see the dynamics of glucose metabolism. We developed a body setup for doing body DMI in humans at 7 Tesla. So it's a posterior and anterior coil element, both containing 2 deuterium loops. And this gives us coverage of almost the whole abdomen. And so here you see an example of a DMI data set in the human body after administration of deuterated glucose. And so if we pick a voxel in the stomach, then we see this series of spectra as a function of time. So we followed, we did DMI scans up to about 2 hours after glucose administration. And after the baseline scans, which are flat here, you see here the glucose signal, which is very, very intense in the stomach, decays slowly as a function of time. But at the end of the experiment, so 2 hours after intake, there's still a lot of glucose present in the stomach, which seems a waste. And actually, there will be a talk later in the session where they try to reduce the glucose dose. In the liver, we see very little signal in the beginning and a slow increase. And we know that this signal is from glucose and not from glycogen, which would overlap. But Henk de Vijter showed that the T2 relaxation for deuterated glycogen is so short that we cannot pick it up in vivo with DMI. And we can also actually pick a voxel in the kidney, which looks quite similar to the liver. I will skip this slide, I think, in view of time. So we also started to do some DMI scans in skeletal muscle. Well, this was actually just Deuterium MRSI because this was at natural abundance. And we were a bit confused initially because when we looked at the spectra, we saw this splitting in a deuterated water signal. And the splitting was different in the different muscle groups. So it was biggest in the tibialis anterior muscle, a bit smaller in the gastroc, and not really visible in the soleus. So when we thought about this a bit deeper, then we could explain this by the incomplete motional averaging in the highly ionotropic muscle tissue. And this leads to residual quadrupolar couplings in your deuterium spectra. And this is similar to the dipolar couplings that you observe in proton spectra in skeletal muscle. We also performed DTI experiments, a DTI experiment in this volunteer. And we determined the muscle fiber angles. And we could demonstrate that the residual quadrupolar couplings that we observe, that they depend on the angle between the muscle fibers and the B0 field. Now, We have heard already a lot about acceleration during this workshop, and this is also something that becomes important for DMI, especially for the large matrix sizes that we need, for example, for body applications. So with a simple MRSI experiment, this is very inefficient. And there's different approaches that you can take, and this is an example by Kyung-Min Nam from our group, and he implemented a Deuterium MRSI sequence to speed up the acquisition. And whereas for a normal MRSI experiment, this to collect such a matrix would take at least 20 minutes with a single average, Kyung-Min could bring it down to 2 minutes with this Deuterium MRSI scan with still sufficient SNR. This is without denoising. And Kyung-Min Nam will have a presentation later in the session where he will present a different approach to accelerate. This is another example done by Dana Peters. And what she did is she developed a multi-echo balanced SSFP sequence where she used 5 echo times, which are tuned to have clear different phase accumulations for the 3 metabolites of interest: glucose, lactate, and water. And she applied this in a pancreatic tumor mouse model. And the top row is a normal MRSI experiment, and the middle row is the balanced SSFP with a similar matrix size. And if you look at lactate, then you can see that in a normal MRSI sequence, with this acquisition time, there's only noise, whereas with the same acquisition time in the balanced SSFP, you see a clear lactate signal at the site of the tumor, which is supposedly here. And she demonstrated that compared to the normal MRSI, the balanced SSFP has a SNR gain of a factor 2 to 3. Another way to make things faster is actually to combine different experiments. So this is an example from the Yale group, where they interleave DMI with a normal proton scan, a flare image. And what they did is they used the dead time in their proton experiment to put in, to squeeze in deuterium pulses and deuterium acquisitions. So in this way, they could, during the time that they would need to acquire a flare image, they could also run a full DMI scan of the brain. So here you see the resulting DMI data set, and these are 4 slices of the flare image. Now, there's also another way. So I talked about indirect detection in the very beginning of the presentation, and this has actually also been used to look at the metabolism. And this is an example in the rat brain, where you see here a proton spectrum from the brain, and then here are proton spectra during the infusion of deuterated glucose. And what you see is that, so here's the glutamate H4 signal, that this signal decreases as a function of time. And this can be understood because part of the glutamate pool will become deuterated and will no longer contribute to the proton signal. So then if you take different spectra, you see here a signal coming up at the glutamate H4 position. And they validated that this is actually representing the glutamate signal by interleaving the proton scans with deuterium scans, so for direct detection of glutamate, and they observed a good correlation between the two. And this is an example from the same group, but then in humans. So here you see the glutamate over NAA maps at baseline, and then during the infusion, after administration of deuterated glucose. And also here you see a decrease in the protonated glutamate signal. Of course, the big advantage of this approach is that you do not need any specialized hardware. So you can do it on your normal scanner. The downside is you need very stable scans. And whereas this may work in the brain, it may not work in, for example, body applications. Now, the last slide I have, I will only go over very quickly. The next talk will about hyperpolarized carbon-13 MR. And well, you can also look at metabolic processes with this technique. It's not directly comparable, but the question may be, okay, can one replace the other potentially, or do they provide different information, and are they complementary? So here a comparison was made between DMI and hyperpolarized carbon-13 MR using different substrates, so deuterated glucose versus hyperpolarized pyruvates. So the metabolism is not exactly the same. The way of administration is not the same. So there's a lot of differences. And actually also in the results, they showed that, yeah, there were differences and that the techniques could be complementary. But I will not go into the details, but because again, later in the session, there will be a talk also on comparing these two techniques. So in conclusion, DMI is a very simple and robust method to map metabolism in vivo. Because of the very low natural abundance, there's no need for water or lipid suppression. And because of the low T2s, the technique is relatively immune to magnetic field inhomogeneity, which makes life a little bit simpler. The short T2s make that we can do very rapid signal averaging, which gives us a good sensitivity. And with this good sensitivity, we can reach quite high temporal and spatial resolutions. And we can use actually a wide variety of substrates. So the initial experiments were mostly done with glucose, but there's many more other options. So we can potentially map a lot of metabolic processes. And this is a quote actually from the paper here by Henk de Vijter and Robin de Graaf, saying that the future of DMI looks very bright. And finally, I would like to thank my collaborators in Utrecht and also Henk de Vijter and Robin de Graaf, and you for your attention.
Thank you for the great talk. The podium is now open for questions.
Fantastic talk. I was wondering, your data showing from the stomach and the endogastric sort of emptying issue, is that smaller on 70 due to the high resolution? I mean, we've looked at it at 3 Tesla, and we get a huge partial volume effects, and which really makes sort of quantification of all the other organs very difficult.
Yeah, that is actually an issue. And well, of course, we could have expected this high signal in the stomach, but we didn't really think about it at first. So yeah, there's massive contamination to neighboring voxels. In our case, it was actually a good thing that, so we have B0 inhomogeneity, right? And so there was quite a shift in the position of the glucose signal in the stomach compared to the glucose signal in the liver. So that is how we could discriminate in our liver voxels, the glucose really originating from the liver from the glucose originating from the stomach. But this was also very coarse resolution. So to reduce this problem, we should go to higher spatial resolutions. But then, yeah, we really need accelerated techniques to be able to do that. But yeah, and maybe going to lower glucose amounts could also be an option, but we will see later. Yeah.
Thank you.
Any more questions, maybe from the students? Okay, not the student, but.
Can you comment?
I can repeat it. Yeah. So the question is if I can comment on the cost. Yeah. So, well, that's actually an advantage compared to carbon-13 that I didn't talk about. The costs are definitely lower than for carbon-13, but it's still not cheap. And so very roughly, so if you use this 0.75 grams of glucose per kilogram body weight, so that's about 50 to 60 grams for an average person, then it's still around 1,000 euros per experiment. So that's not cheap. And unfortunately, recently also the prices went up. I don't understand, but I was hoping that the more people would be using it, the price would go down. But yeah, it's also, of course, a question of offer and request. So yeah, the prices are now actually going up. So yeah, but hopefully in the future they will go down.
One point to that, while it's very convenient now for the first experiments or first studies to have the oral administration, then especially for brain measurement later on, I think we should switch to IV infusion, because our
a lot of the glucose will get picked up in the liver. A lot of the glucose will get picked up in the first passage in the kidney. So we can reduce the load or the amount of the glucose administered if we are going for the brain, for example, by IV administration, I think.
Yeah, well, yeah, that's the question. That will lead to higher costs because we now use a grade of glucose that can only be used for oral administration. And if you have to go to the grade that you can use for IV, the cost will go up quite a lot. I also don't know if it's really needed to go to IV infusion. Of course, all the carbon-13 measurements or most of the carbon-13 measurements were done with IV infusion, but yeah, I talked with Anke Henning during this conference, and the great thing about deuterium is we also measure the glucose signal itself. So maybe it's not needed to do the IV infusion with the very stable glucose concentrations, and we can actually continue with it. So then I don't know if it will be beneficial to go to maybe a lower dose, but IV grade, which is then again more expensive, or use a bit more, but still do it orally.
I mean, the other way around, if we want to place it in a metabolic research, they will ask for plasma concentrations and things like this. So
yeah, but we
kind of blood drawing and IV infusion and standardization will be necessary.
Yeah, but blood drawing we can do as well.
Nice
blood drawing we can do it as well, of course. That's no problem. That's yeah, and we should do it. Yeah.
So if there are no more questions, let's
And from my experience from metabolic studies, and if we are going to do such a longitudinal or like 2-hour study, the blood drawing will be necessary. The enrichment of the glucose of the substrate in the blood will be necessary, and so on. So if it's used as a contrast agent, as for
yeah, but that you can do equally well with oral administration, of course. So that's not an issue. Yeah, yeah.
Okay, one last question.
Just a really quick comment on the infusion. It's a great idea, and we actually are allowed to do it, and our doctors do it for other studies, and we buy the same dirty glucose, and we just get our local
okay.
We just get our local pharmacy to sort of pass it through to
to make it sterile,
and then then you're allowed to use it. So and that's not very cheap or expensive actually. So
yeah. Okay, that's great. Yeah, on the other hand, I mean, the oral administration, maybe it's a more physiological route, so that also, some people also like that. So yeah, pros and cons.
Okay, let's thank Janine again for the wonderful presentation. And with that, would like to introduce our next speaker.
The next speaker is Christopher Lotzen from the MR Research Institute, Department of Clinical Medicine in Aarhus University in Denmark. And the title is Hyperpolarized Carbon-13. Where are we in the clinic?
Hello, can you hear me all right? Yeah. What a fantastic meeting so far. I really enjoyed it, even though I'm slight on the fringe of proton mass spectroscopy. Yeah, so I was asked to sort of give you a short introduction to where we're at with carbon-13 hyperpolarization, and it was sort of alluded to earlier that I might say a few things about that. So this is sort of the outline. Firstly, I'll sort of introduce, for those of you who don't know, what is hyperpolarized carbon-13 and the dissolution DNP in particular, and how did we translate it to clinical use, and then I'm going to sort of finish off with a few cases from our lab in Aarhus. So first of all, hyperpolarized carbon-13, and in particular dissolution DNP.
enhances the signal more than 10,000 fold. It's actually more or less 30 to 40,000 fold nowadays. It doesn't rely on any ionizing radiation because it's MR technology. It's similar, as you know, the signals are specific to chemical structures, and that allows us to look at more than one thing at a time. And several groups are doing human studies as of now, and this is sort of from the first human study, which I'll come back to. So how do we do it? Well, we start with a big magnet. This is typically more than 3 Tesla. Then we need a freezer that is typically below 1.4 Kelvin. That's liquid helium. And then we need a microwave oven that operates at a specific frequency, which is determined by the magnetic field. Then we also need an electron donor. So we're using an electron to carbon transition. We need a sugar substance. So we have a free electron donor, and we have a sugar substance that is typically pyruvate. We call that the radical. And then we need an electric cooker. This is rather standard electric cooker that allows us to heat up water. And then we place the radical together with the pyruvate or the sugar substance into the freezer in the magnetic fields, and we let it sit there with the microwaves on, transferring the polarization to the carbon-13 in this case, so that we get this high signal. And then eventually we decide to start the experiment, and we take some water and place in the electric cooker, and then we heat up the water to 130 degrees, and we pour this very hot liquid on top of this little ice cube in the system, and out of it we'll get a very much enhanced signal, which is sort of a green monster of a signal, which is more than 10,000 fold enhanced. And this is how it looks. And this is the sort of the original design from Jan Henrik. And you can see here, this is a pretty standard NMR system. You have the freezer down here, you have the sample in the freezer, you have the cooker up here, and you have a microwave guide going here, which allows us to irradiate on the sample. So we're ready to do the experiment. We are heating up the water in the electric cooker. We're pressurizing the sample space. Then we are raising out of the sample space out of the liquid helium here, the sample, so that we don't have a massive heat loss. And then very rapidly, we'll put this stick on top of the sample, and then we'll take the very hot liquid and dissolve this ice cube. And then we'll get this green liquid out. And this is how it looked back in the day. This is from Oxford University. And so she's standing with the electric cooker here. And then Mike is pressurizing the sample space. He's very automatically rising the sample out of the space. Now you get the green liquid out, and now she runs. And now she's injecting the hyperpolarized substrate into the tail vein of a rat in this case. And this is a C2 pyruvate experiment, and what you're seeing here is real-time metabolism as it unfolds. So this is the only technology that allows us to really follow these extremely fast processes. So this is another type of contrast that was sort of mentioned in the previous talk. But it has sort of similarities. So we have our carbon-13 labeled in this case on the one position. This is our FDG of the hyperpolarized community, if you will. And what happens is that will be taken up by the monocarboxyl transporters, and in the cytosol, it will be converted by enzymes into lactate, alanine, via lactate dehydrogenase or alanine transferase, or be taken up into the mitochondria, where it be cleaved up in the pyruvate dehydrogenase. And that is in direct equilibrium here with, so CO2 is direct equilibrium with bicarbonate. This is the signal out here. We can also detect CO2, so we can actually map pH if we want to.
but that lies further downstream. But this is a sort of a typical experiment, and this is how it actually works. So just sort of to re-emphasize, hyperpolarized MR is very different from any other metabolite or imaging technology, because what we're injecting here is the actual substrate of the signal. So it's not like when we're doing a gadolinium injection where it actually is a modulation of the surrounding tissue. So it's something similar as the DMI technology, but this case, we just have a very rapid in the sort of decaying signal. That was why she was running, but also a quite different type of dynamic data. We are limited to very fast processes, and this allows us to actually do more than one injection in a very rapid pace. So we can do multiple injections and follow different pathways and et cetera. So this is in many ways very similar to water PET, which is a strength of this technology, I believe. Hyperpolarized MR is quite difficult, and that's why there's sort of a room like this, it would be very exciting for a lot of people, because we inherently span a 5-dimensional space, so we really need fancy sequences and a lot of sort of insightful thoughts on how you analyze and reconstruct the data. We've come quite a way. So this is a typical experiment of the kidneys. So what you're seeing here, we have a renal occlusion, sort of a local in the kidney here, and you can clearly see that sort of in the perfusion of the metabolite of the pyruvates that we've injected. But then, in addition to this is what we're doing together with Rolf Schulte from GE. And then Rolf has developed this sequence where we're mapping the perfusion and also getting these metabolic images out, as you see here. And then you can get sort of a Michaelis-Menten, like an apparent Michaelis-Menten rate out. So you get metabolic information, but in addition to your perfusion information here. So it's sort of quite a exciting experiment for us. And so one of the sort of the questions were, does this actually look anywhere similar to our conventional gadolinium contrast? And indeed it does. So we're using this experiment where we're using a spectral spatial approach to image lactate, alanine, and bicarbonate, sort of with a lower temporal resolution, but paired with a high resolution, but a low flip angle, because we're eating up the signal as we go. So it's all of these trade-offs that we have to sort of consider when we're doing this experiment. But it turns out that we actually get sort of really similar perfusion information from these pyruvate scans, in addition to the hyperpolarized scans. So moving on to sort of the clinical use of this. So that was really spearheaded by the UCSF team. And they started using a similar system as you've just seen in a clean room. So they modified it and then had to stand in these clean room suits here. And that was a really tough experiment to do, but they managed to do the first sort of in-human trial. And this is data from the first patient. And similar to the previous talk where we have the Warburg effect, so this is a cancer. So you have a cancer here, this is a prostate cancer. So you have an abnormal high production of lactate in the cancer, but in the sort of normal appearing part of the pancreas or prostate, sorry, you don't see any lactate in this very first data. They went on to do 31 of these patients, and there were no sort of complications with the injection, so it's deemed safe and well tolerated. They had one patient that did not, on the conventional MRI or any other technology that they were using, show any signs of bilateral disease, but on the hyperpolarized scans, this is a CSI image. It actually turned out to be there was an additional spot here on the other side. So they took the patient out and operated the patient, and it turned out that the patient actually had bilateral disease. So this is really sort of shows you what the strength of doing something that is metabolic gives us this additional sensitivity and specificity. So as you saw earlier, this was the system that was sort of developed for preclinical purposes. So the prototype of the alpha polarized, as we call it, that was developed into the clean room and also into a preclinical system that is now not available anymore, the Oxford Hypersense. That has then been developed in 2018 into what is called the spin aligner, again from Jan Henrik, this guy here. And also it was developed into a clinical, so the clinical sort of path of it was sort of paralleled, went into developing the GE spin lab, which is what is used for clinical studies. I'm not going to use a lot of time on this, but it's sort of a easier to use system, and it uses a sterile fluid path, or pharmacy kits as it's called nowadays, which allows us to have these sterile components and prepare a drug for use in sort of a normal MR facility. We have the ability to have 4 of these samples in, so we can do multiple injections in the same patient. And then where there's some quality control assurance connected to it, so that we can make sure that the substrate is good to be injected. Right now, there is 25 of these installed, and it's more on the way. Of these 25, there is 15 undergoing clinical studies, and we are among them. And there's actually 2 in Denmark, largely because Jan Henrik is Danish, so we had a head start on doing these kind of studies in Denmark. But for now, there's been more than 60 publications with clinical data, and over 750 exams so far worldwide. Most of them has been in cancer, and then so here's an overview. But the most important sort of take-home message from this is that we have not had any serious adverse events reported. So this is really positive, and it's really well tolerated. Sort of moving on to a few cases, we started in pancreatic cancer. It's a very serious disease. We did our first experiment in 2018, and we had Jan Henrik visit himself at the day, and so that was a great day. And you can see there's a lot of people involved, and we're not running anymore, and the injected hyperpolarized pyruvate is not green anymore, so it doesn't look hyperpolarized, but we actually managed to get some results, and we were really happy. Took a lot of effort to getting there. And so this is data from the first patient. This is just spectroscopy, so we don't know if it's from a tumor or whatever it is. But we went on and did a imaging scan in the next subject. And already here, we sort of stumble upon something that I was not aware of that we would find or anticipated, which was that we saw quite a high alanine signal coming from the pancreatic cancer and the pancreas in as a whole. And it turns out this is sort of a very specific thing that relates to the specific phenotype of the pancreatic cancer that we were looking at. And it turns out that it's a symbiotic relationship where the pancreas is sort of helping the tumor survive. So it's feeding alanine, so it's generating a lot of alanine, and the tumor is then feeding lactate to the surrounding. And so it's sort of a vicious cycle of this very specific cancer type. And so we were quite excited about that. And this is sort of an ongoing study where we are trying to reduce the treatment window for these patients. And another sort of important factor is, can we go and do these experiments, and are they actually comparable between sites? So we decided to do a first sort of initial test of this sort of thesis or hypothesis. So we found 3 healthy volunteers that were willing to use their bodies for these experiments. So there's at least 2 of them is completely unknown for GDPR reasons, as you can probably imagine. But we sent these 3 persons to the US and we scanned them in Aarhus as well with rather similar sequences. And we figured out that we actually get quite good agreement, even over, this took over a year to do, partly because of Corona. And it turned out that we actually get quite good numbers between the 2 sites, which is positive. And that also means that we are actually able to start sort of moving to multi-center studies. So this is sort of the first initial considerations moving in that direction. Another sort of area that we've started looking at is ALS, where the initial data didn't suggest that would be a wonderful idea, because we have the blood-brain barrier, and this is an experiment that sort of is rapidly gone. But it turned out that I was mistaken. And this is data from our first ALS patient. And the patient has sort of symptoms, burdens that are related to one side of the hemisphere. And it turns out that we are actually seeing an upregulation of metabolism in that part of the motor cortex that is responsible for those symptoms. So this is something that we're really excited about, and then our neuroradiologist is really pushing to start to use this technology for evaluating these patients. And another sort of obvious thing with metabolism is looking at, this is the failing heart and engine out of fuel is sort of a quite well-known statement, and what we're investigating here is to use this as a different tool rather than using FDG PET for looking at the cardiac reserve or myocardial viability. And so we started out with the initial experiment here to see if we can use sort of the conventional stress test cardiac exam. And what you're seeing is that a hyperpolarized exam in the sort of the rest gives decent images in this case, but not super great. But at stress, you increase the workload on the perfusion to the tissue, and therefore you also increase sort of our SNR. But more importantly, you also increase the metabolism overall for all metabolic pathways, and it sort of corresponds to how fast your heart is beating. And so this is something that would be different if you have heart failure, and we've started the heart failure studies as well. And this is sort of the conventional test, is to do this rest stress exam, and then looking at, if you fall off of this, then you know how bad it is. So just sort of to sum up, hyperpolarized gamma-13 is not based on ionizing radiation. The signals that we get are sort of specific to chemical structures. That essentially means that we can look at more than one thing at a time, which is similar to what you're doing, but we're looking at the dynamics of these experiments. So it's a contrast experiment where we're seeing a dynamic change. The hyperpolarized signal is enhanced more than 10,000-fold, and there's no background, so it eases the analysis quite a bit. So it's very easy to sort of do the analysis because we're only looking at these dynamic curves. And there are many more sort of really good clinical studies underway. I've only shown you a few from our lab, but there's a lot of really exciting studies going on. And with that, I would like to thank you for listening, and the team for doing all the hard work. And then I just have one sort of final slide here, that we're hosting a workshop later this year, where we'll be using all of the 3 sort of hyperpolarized technologies that are in use in Aarhus. So we have the spin lab and the spin aligner, so that's the 2 DNP apparatuses. And then we have the xenon polarizer from Jim Wild. So we're gonna have a very exciting meeting there where you get hands-on experience doing these experiments. And so if you know of anyone, please go in and sign up. It's going to be very exciting. We have all the really the inventors of the individual technologies there, and they'll be showcasing their own technologies, and there'll be a lot of fun pig experiments, and I think it's going to be exciting. Thank you.
Thank you very much. We have time for a few questions.
This is an incredible talk, and thank you so much. This is really kind of amazing. A quick question, maybe I didn't catch it. What do you do to minimize the time between delivery and the time it reaches the specific organ that you want to look at, if it is pancreas or if it is the prostate, etc.?
So in vivo, we don't do anything. I mean, you in principle, you can sort of inject it directly into the individual organs, but we just place a venflon in the venous side. So it's just conventional injection with a power injector. So there's no sort of trick to it. It acts as a bolus, and there's many thoughts on exactly how that actually happens, but it actually has a longer T1 in the body than you would think. Outside, it's 60 to 70 seconds for pyruvate, but in the body, it's also quite long. What the underlying reasons is, I have sort of like a moving bullet or something, but we don't really know what it is. But it can go anywhere. So there's not an organ you cannot see with pyruvate, at least.
Very nice talk. Thank you. What was the disease stage of the patient with ALS? Soon after diagnosis, or wheelchair bound?
No, it's just after diagnosis. For a lot of these experiments, we tend to take very early in the disease state, and this is mainly due to sort of logistics reasons or setting up the experiments. And it's a good point that depending on how sick you are, some of these experiments is very difficult to do. So yeah.
Changes, the better. So exactly the time to do these measurements. So that's great.
Sure, but I mean, we have other studies, for instance, in stroke, where the logistics of it, because we're a lot of people, we have to prepare the substrate. So it's ALS is a good disease in that way, but there are other diseases where you would want to scan very quickly, where it's not necessarily the easiest. And yeah, so, but I take your point that in this case, yeah.
Any other questions?
So what the cost? I mean, so yeah, so this is a quite expensive technology as of now. So my take on DMI is, and we also do DMI, that is a very cheap technology. So I don't put that in that. But in respect to DMI, this is 4 to 5 times more expensive per patient, sort of roughly speaking. So it's not cheap. It's going to go down. There's nothing inherent in the technology that should make it be expensive. I mean, but right now, because there's so few of them, it is very expensive.
Hello, can you hear me?
Yeah.
Thank you. This was interesting, and I loved the humor that you gave with a straight face. Right? There was humor. Okay.
Yep.
So this is a question I've had a few times today, but it's good to hear that you showed the test, multi-site. You had your phantom human who traveled. And it's promising, but it's 1 or 2 people, right?
It's 3 people, and they were scanned quite a few times, but
it's impressive. Yeah.
But you're right, and it has not been done in animals either. So we didn't know how well. So this was an initial thought about trying to do a multi-center study. We intended to include more So I'm not criticizing.
No, but you're right. I mean, this is not a real multi-site study. It was a test if we were ready to go that route, and it turns out that we think we are,
Yeah.
which is positive. But on the other hand, that will require quite some work.
So that was my question. So for the future, for all of us, I guess, it will require a lot of money to do all the validation we would love to be able to do. And I'm wondering where you think that money is potentially could come from. I find it's very hard to find funding, at least from like an IMH to do a lot of that, like the rigorous validation work that you want to be able to do. So that's my question is where would you look?
So the study that we did was cheap because we had the NIH funded center at UCSF as part of it. So they, it's free to talk to them and it's free for them to make these scans because they get a lot of money. We had to get the money for it elsewhere. And of course, getting a multi-center study up and running, and that's so the motivation for that study was to demonstrate that we would be able to do it, and therefore we should try and see if we can get the funding for it. So it's sort of the data that was needed to try and raise the funds for it, but it's going to be a very big effort to align all of these different scanners and groups that are doing these experiments. So yeah, it's a big effort, and one of the major issues is that we do not really have all the vendors represented in this community very well. So it's very easy to find GE scanners with this technology because they invented it, but it's much harder to find Siemens and Philips scanners in this area. So that is going to be a problem for sort of a multi-center study, which requires all the vendors and equal kind of distribution. So it's not going to be easy.
Okay, thank you. We need to move on. Yeah, I'd really like to encourage everyone to go to the microphone, even if the question is short or it seems not necessary, because not everyone hears the same way. Thank you.
So next up, we'll hear a talk from Kyung-Min Nam about retrospective undersampled 3D deuterium metabolic imaging, DMI, of the human liver with low rank and subspace modeling at 7 Tesla.
Hello, everyone. Today, I will talk about the retrospective undersampling 3D DMI of the human liver with low rank and subspace modeling at 70. Deuterium MRSI is already introduced from the Shannon, so I usually focus on the methodology part. I have no financial to disclose. So DMI is an emerging technique to study metabolism in liver using deuterated glucose. The failure error demonstrates the DMI by mapping metabolism in the brain and liver of the animal models and human subject. Here is a workflow of the typical DMI study. After deuterated glucose intake, the subject can relax outside of the magnet for 30 to 45 minutes while deuterated substrate is metabolized into a number of the downstream products. The acquisition of the DMI data is performed as 3D MRSI study, whereby each spatial location is characterized by a deuterium spectral signature. The quantification of the deuterium spectra at each spatial location by spectral fitting is metabolite maps for individual metabolic substrate, for example, the glucose and downstream products, GLX and lactate.
With a TR of the 333 milliseconds and 8 averages, the typical steady state DMI study is lasted around 29 minutes. So even if DMI has a potential to be a powerful tool to assess the metabolism, it has a limitation due to the long scan time or like a low SNR for high spatial resolution in the body. So to enable metabolite detection in low SNR data when increasing the high spatial resolution and or reducing the acquisition time, we implemented low-rank and subspace reconstruction of the 3D DMI data for human liver and evaluated fidelity of the accelerated MRSI acquisitions at various the acceleration factor by undersampling data retrospectively. One volunteer was scanned using 70 MR scan with transmit receive body array. The 3D DMI data set of the human liver was obtained 2.5 hours after deuterated glucose intake. 3D Hamming weighted acquisition was used, and its pattern is shown below when weighted average is 4. For the reconstruction, our approach employs a low-rank and subspace modeling, which is an unconstrained space, where the temporal subspace is estimated from the fully sampled K-space center region. The unknown spatial basis U is estimated by solving the following least square problem as a below equation. So the linear operator omega is a selected K-space data according to a Poisson disk sampling pattern. The 3D Poisson sampling pattern was shown in above when the reduction factor is 2.5. The Deuterium MRSI dataset of the human liver after oral intake of the deuterated glucose was processed two reconstruction methods. One is FFT, blue line, and low-rank and subspace modeling, the orange line. The MRI image shows the liver controlled by the yellow line. The deuterium spectrum of the selected one boxer, so shown in this spectrum by reconstruction 2 method, and the average SNR of the water peak was calculated in the liver gray region of the middle slice. So average SNR of the ROI of the liver was approximately 3.3 fold higher for low-rank and subspace modeling compared to FFT reconstruction. Following the previous slide, the average SNR of the liver in the middle slice was calculated according to reduction factors such as 1.5, 2, and 2.5. The average SNR of the water peak in the liver didn't show significant changes at this reduction factor. The deuterated glucose and water maps were generated from fully sampled, this R equals 1, and undersampled. The overall normalized root mean square error was calculated and gradually increased as the reduction factor is increased. In conclusion, this study demonstrates the implementation of the low-rank and subspace reconstruction and undersampling 3D DMI data for the human liver at 70. Our reconstruction method shows that noise level reduction in the deuterium spectra enable metabolite detection in low SNR data for the full K-space sampling data, and we have evaluated the fidelity of the accelerated MRSI acquisition at various acceleration rate. The metabolite detection could be improved when the spatial resolution is increased and or the acquisition time of the 3D Deuterium MRSI could be reduced for the high temporal resolution during the dynamic scan. Thank you for attention.
So are there any questions? I would have one question. Did you calculate the RMSEs? Because you showed the SNRs, but we know with this denoising approaches, basically the SNR is like not so meaningful anymore.
I mean, this part.
Did you calculate the error, the root mean square error or something like?
Yeah, so in this case, I cutting the root mean scale as is less than 10%. So, but SNR is still high in when the reconstruction method for like a low rank and subspace modeling. But the reason is things, the reconstruction path like equation is very simple because usually the SPICE technique, the equation is very difficult, but simply thinking, so we have only unknown variable is U. So for example, the first day, the Antonian explained about like a compressed sensing using the TGB. So he has some unknown variables too. That means the solution is a little bit hard to find it. So in the SPICE method, the temporal method is temporal basis is already fixed it, and then unknown variable is only U is 1. So that's why the solution is simple and there is a noisy effect shown in the result.
And one other like commenting question, like you only undersampled in the K-space, right?
Yes.
So like it's just a comment, but like that's not really SPICE because in SPICE you undersample in time, and you need some like kind of EPSI or like some spatial spectral encoding trajectory.
That's true.
Like, but yeah, it's
just SPICE technique actually is a reconstruction method instead of the acquisition, but the first method is 2014 Farlam. So he integrated the acquisition and reconstruction method.
Exactly, like it's an acquisition and reconstruction. They undersample always in time.
Yeah, that's true. So in the last like presentation, the Shanin, we already implemented the EPSI. So next further study, we are integrating more like a faster acquisition with this method.
Very nice presentation. Can you show the slide before I didn't? You showed the the acquisition parameter. So you didn't use any EPI. I have a similar question like Bernard. You didn't use EPI at all, right? During the acquisition, it's just kind of phase encoded acquisition, or am I wrong?
Yeah, that's true. So we are only acquisition part is only for 3D Hamming weighted. So it's not really fully acquired in the case space. But in this case, we are a little bit variant.
Did you have any problems with motion for during 10 minutes or not? Like how was the like breathing motion? Like is there the quality of the data that you get, like when you this is like there was any gating, any gated acquisition, or it was free breathing and continuous acquisition during these 10 minutes?
That's a good question. It's also further study, so we didn't use any gating, but so yeah, it's a liver is definitely is moving in the body. So yeah, so SPICE. Actually, the latest version of the SPICE technique has already included the motion correction part. So we are still like studying.
So you had in the reconstruction something for the something that took care of the motion. Yeah, so you said you had something in the reconstruction that.
Yeah, we have a plan to making some navigator after readout for 3 direction SAAP head. And then we will use that information for reconstruction part in the next study.
And the only two things that you saw in the spectra are just water and glucose. There was these are the only two signals that you see in the spectra.
Yeah, in the liver, this is a healthy volunteer.
Yep.
So we can see the water and the glucose, and some reason in the boundary of the liver, there is some lipid signal in there. Yeah. So now we can find the three different metabolites.
Okay.
So if there are no more questions, let's thank Kyung-Min Nam one more time. And move on to the next presentation.
Our next speaker is Mor Mishkovsky, comparing cerebral metabolism of hyperpolarized compensating glucose and thermally polarized deuterated glucose under different anesthetic conditions.
So it's great to be part of this excellent workshop. And it's an opportunity to thank the organizers for the opportunity to present my study. So I found my title somehow long when I prepared the slides, so maybe we quickly move to a comparison of ex-nuclear MRS of metabolic precursors. So what we share with hyperpolarization and with ex-nuclei like carbon-16 glucose or deuterated glucose, that we take a molecule that is interesting biochemically or biomedically, we label with NMR active nuclei. Luckily, with both these tracers, we have very little background signal. So basically, it's a background-free methodology. And then we have our NMR signal. If we look at the thermally polarized signal, the signal is proportional to the difference in the energy level. To be correct, this energy level will represent carbon-13 because it has been 1/2. For the deuterium, we will have 3 energy levels, but still the signal will be proportional to the difference in the energy level, the Boltzmann distribution. In the hyperpolarized case, we will force the system to have a huge difference in the population between the 2 energy levels. We are using carbon-13 or usually spin 1/2 in this case of experiment. And this is how we create our huge signal. We boost the sensitivity of the experiment and we get this out of equilibrium, very strong signal. So we have our signal and now we need to give it to our patient. So I'm doing preclinical, this is my patient. And if we do thermally polarized MRS, we have different routes that we can administrate our precursor into the patient. We can do infusion, long infusion, which is commonly used in carbon-13 MRS study. We can give a bolus, we can give an oral intake. In the hyperpolarized case, we will use the bolus injection. As Christopher explained, we are running with time. We don't have a lot of time to detect our signal, so we need to be very rapid with administration. Bolus is a good compromise. Of course, having a huge signal, we will then use lower doses than what is typically used with thermally polarized spectroscopy. As of what is happening next is that we want to measure what is happening with our molecule inside the magnet. So we have our labeling and it will start to distribute into the different metabolites based on the metabolic pathways. And we will try to measure the NMR signal of this transfer of labeling. So in the thermally polarized case, typically experiment will be longer. We need to have certain amount of signal to be detectable. And the total acquisition time will be in hours with a time resolution of minutes. In the hyperpolarized case, the total acquisition time will be in the minute time scale with a time resolution of seconds. So you can see that there are similarities and differences between these two tracer modalities. In the hyperpolarization method, as Christopher mentioned,
that in the workshop, there are different modalities that we can create hyperpolarized signals. The most versatile technology is the dissolution DNP, because what we will need is the molecule of interest with the polarizing agent to put them together, to shine microwave, and to create a hyperpolarized signal. So since the development of the knowledge to do that at 1 Kelvin with this electron nuclear polarization transfer sequence is known for many years, but the main breakthrough to put it into a biomedical context was in 2003 with the landmark paper of Anders Larsen, that he managed to create solutions containing molecules that are hyperpolarized. And then he showed that he can inject these solutions into animals, later on in patients. And over these 20 years of development, almost nowadays, I just quickly checked yesterday in the clinical trial website, there are 25 clinical trials, more than 25 clinical trials registered. So the technology evolved very rapidly, and the main focus was with hyperpolarized pyruvate. And the reason is because hyperpolarized pyruvate, which is sitting here in a very interesting metabolic junction, is the exceptionally excellent hyperpolarized precursor. And when we try to judge how good is the hyperpolarized precursor, one very important thing is that we could have a highly concentrated substrate. Basically, we can use nitpyruvic acid to dope it with the polarizing agent. We get high polarization, and also those polarization last quite long. And this is given by the T1. It's related to the lifetime of the hyperpolarized molecule. And it's exceptionally excellent in all these categories. Of course, being interested in brain metabolism, glucose is the biochemically more natural substrate to go, because glucose is the main fuel for the brain, and many pathologies will be associated with changes in glycolysis. But if we go into our hyperpolarized parameter criteria, we can see that even if you use deuterated glucose, in which the T1s are already longer, the lifetime, the concentration, and the amount of polarization we can get is much, much lower. With the main challenge will be that we don't have a lot of time. The short lifetime of the precursor will be a very big challenge to overcome. So when we started to be interested with hyperpolar glucose in our experiment, what we knew is that we can hyperpolarize deuterated carbon-13 labeled glucose. It was shown in yeast that you can measure the glycolytic pathway by Sebastian Mayer. It was also demonstrated that you can actually hyperpolarize glucose and to take an image of hyperpolarized glucose in the abdominal, but there were not much metabolic studies. The only metabolic studies was a study from the group of Kevin Brindle, where they studied like lymphoma tumor metabolism. When they detected in the tumor, they could see increase of lactate in the tumor and the different model of the lymphoma tumor. Interestingly, in the brain, they couldn't detect any signal of lactate being produced from the bolus of the hyperpolarized glucose. So we knew that if we want to detect anything with glucose, we need to go back to the protocol of hyperpolarization and to optimize each and every step in this process. So our system, it's a custom designed system. It's a 7 Tesla polarizer operating at 1 Kelvin. And we are using deuterated glucose, or cis13 fully labeled with cis13. We are using trityl radical, which is more efficient for the polarization process. And after 2 hours, we can reach to a much higher polarization than in previous report. At the time, we could produce 20% of polarization. Nowadays, we managed to produce more than 40% polarization. And we have the very unique protocol where we rapidly dissolve the sample. We take this hot water from the kettle of Christopher. We put it inside our magnet. We take it out automatically in 3 seconds and collect it in a separator infusion pump that is already located in the scanner. This pump is then connected to the femoral vein of our patient, to the mouse, and we give the bolus of the glucose. At this stage, we are using surface-based localization, so we put a coil on top of the mouse head. And in terms of the acquisition, we know that glucose will relax very rapidly. So we use the frequency selective excitation with Gauss pulses, knowing that we will hardly touch the glucose area in this very sparse spectrum. We focus on the carboxyl area. We give a ray of 20 degrees of nominal 20-degree pulses in the carboxyl area here, where we would expect to have the metabolites with the longer T1, but we are hardly touching the glucose. So this is what we see in the mouse brain. You can see here the glucose. It's not so difficult to see that we see glucose over the 50 seconds acquisition with a time resolution of 1 second. But when we look at 183 ppm, this is the signal of lactate that was produced from this hyperpolarized glucose. It is important to mention that the glucose, that the lactate that was become labeled from this bolus of glucose is a consequence of 12 biochemical reactions. So we have the glucose uptake, the 10 steps of glycolysis, and then the LDH-mediated conversion from pyruvate into lactate. In the hyperpolarized pyruvate experiment, we will bypass a lot of this reaction. The pyruvate will enter from the MCT transporter to the brain, and then will be exchanged to the lactate pool. So we have this protocol, and when we looked at the sound spectra of this dynamic data, we could also detect pyruvate in vivo in the brain. And when we compared the lactate signal that we detected to the pyruvate signal that we detected, we could see that the ratio will correspond to what you would expect in the normal brain condition from other studies. We could also detect the glycolytic intermediate 3-phosphoglycerate. We then demonstrated that we can improve the sensitivity of the experiment if we will specifically label glucose. In this case, we label the 3 and the 4 position like this. When the 6 ring will break into 3 carbon compound, we will lose the J coupling, and we could increase the sensitivity having a singlet peaks instead of doublet peaks in the spectrum. We then applied in a very special model of glioblastoma. Typically, when we talk about cancer, we talk about the Warburg effect. But in glioblastoma, there is all this area that has a diffusive, it's very well diffused into the tissue, to the healthy tissue. It's very difficult to visualize it. And when you can see here the model of the animals, and in the T2 weighted image, it's very difficult to define where the tumor starts or ends. We don't see any enhancement in the T1 weighted images. In the proton spectroscopy, we couldn't see any change in the pool size of lactate, but when we injected hyperpolarized glucose and when we measured how much lactate being produced in those models, we actually detected less lactate being produced in this tumor compared to the healthy, which is opposite to what we would expect from the Warburg effect. And then we wanted to see how the anesthesia that we are using, focusing on isoflurane, which is the common anesthesia for metabolic study, and the melotomidine isoflurane combination, which is becoming more and more frequently used in functional MRI. And we wanted to see how changes in the consciousness associated with this difference in anesthesia will affect the metabolism of glucose, knowing that glucose is needed for neuronal activity. Interestingly, we saw that when we have the animals anesthetized with melotomidine isoflurane, where the brain is more active, and functional MRI studies showed that the functional connectivity is similar to what you would see in the awake animal, we see much higher lactate being produced from the bolus of the hyperpolarized glucose compared to the case of isoflurane. So we were a bit puzzled about our results, because when we compare the proton pool size studies, the results that we got and what we saw with the hyperpolarized glucose. So if you go back to the tumor experiment, we didn't see any change in the pool size of glucose, but we rather saw a difference in the labeling, a reduction in the labeling of lactate in hyperpolarized experiment. In the case of the change in the brain consciousness with the difference of the anesthesia, we all know that when we have isoflurane, there is higher lactate signal in the brain. It's not 100% clear what is the origin of this lactate, which is known to have higher pool size of lactate. In the melotomidine case, we see consistently low pool of lactate, but actually when we measure the production of lactate over 1 minute during our 1 minute of acquisition, we see exactly the opposite behavior. We see less lactate being labeled in the isoflurane case, where we have higher pool size of lactate and much higher lactate being produced in the metomidine isoflurane combination, where the pool size of lactate is actually lower. So we wanted to look at the question with another tracer modality, and we decided to go for deuterium, and using deuterium, like Jenny showed us. Jenny showed us, it's known from other metabolic modalities for many years.
We have to finish in 2 minutes.
Yes, I'm there. And it was this exciting paper of Flu in 2017 that showed us that we can measure actually glycolysis with deuterated glucose, that then created this very inspiring work of the FAIA that pushed it into clinical application. So we say, okay, let's adapt our protocol and make it as similar as we can to the hyperpolarized case, but now instead of injecting hyperpolarized glucose, let's inject deuterated glucose. So we have our patient in the magnet, we use our separator infusion pump, we use the surface coil, but this time it's the deuterium coil. We use deuterated glucose, we start an acquisition of the reference water that is already there in the brain. We then give the bolus of glucose, we give a bolus of deuterated glucose, and we start to measure the dynamic of the glucose signal. So you can see here, this is the reference water. We gave the bolus, we see glucose, we see water, we see lactate and glutamate. Glutamine, this is animal anesthetized with isoflurane, and this is overall 100 minutes or more or less of acquisition from the first water reference. So if we look at the sum, this is the proton spectrum, we see, as we expect, higher lactate in the isoflurane case. When we look at the sum of the deuterium spectrum over 1 hour of acquisition post the bolus, we clearly detect lactate in the deuterium case, in the isoflurane case, but we don't see any lactate in the metomidine isoflurane acquisition. When we look at the hyperpolarized case, we see much higher lactate when we are using hyperpolarized glucose compared to isoflurane. This is a 1 minute acquisition. So to understand a bit what parameters are more important when we do hyperpolarized glucose compared to the deuterium experiment, we establish a numerical simulation saying that our glucose will turn into 2 molecules of pyruvate, and as we escape to the TCA cycle or convert into lactate, and then the lactate can go out into the bloodstream. So we give our bolus, and then we decide to say, okay, let's say that we fix our lactate pool size and we change the CMR glucose. How sensitive the experiment will be. And we see that when we change the CMR glucose, there is much more variability in the experiment. This is the 60 minutes acquisition where the acquisition of the hyperpolarized glucose ends. When we fix the CMR glucose and then we change the pool size of lactate, we see that at 6 seconds of acquisition, this is where the hyperpolarized glucose experiment ends, we don't see much variation between the results. Then adding the realistic parameter with the losses of the RF pulses and the T1 that we are losing all the time polarization, we see that those differences become much more closer to what we actually observe in our measurement and more pronounced that the CMR glucose is the dominant parameter in the hyperpolarized experiment compared to the pool size that actually has no influence at this very initial step of metabolic reaction. So to summarize, we measure glucose metabolism with hyperpolarized glucose, with deuterated glucose in the mice. And we saw that the lactate synthesis and the dynamic of lactate synthesis is very different with these two modalities under different anesthetic conditions. The lactate from hyperpolarized glucose is not a reflection of the pool size. We are measuring something else, which is more related to the CMR glucose. And when we use deuterated glucose, the measurement in the steady state will be a reflection of the pool size. And overall, we see that brain consciousness and the anesthesia will influence the metabolism of the brain. And in particular, it is also affecting differently these two modalities of X-nuclei MRS. So I just want to thank the people who contributed to the study, in particular to Emma Fly, that was a PhD student on the project, and Bernard, that is here in the audience. And of course, thank you. And I was too late for the cow competition, so I couldn't resist. And I put the cow myself. And thank you.
Okay. You have time maybe for one quick question.
Thank you. Very interesting and very quick question. How much does it cost for this hyperpolarized 13 glucose per gram? How much does it cost?
How much it costs?
Yes.
I think that the cost is more related to in the DNP experiment, it's more related to the helium cost rather than the glucose cost, because the doses are rather small. Nowadays, we learned that the liter of helium is close to 10 francs per liter at the institution. We expect so in a week we are using 100 liters of helium, so this is our main cost. In the deuterium, it's similar to other estimation of other people, but it's the main costs are from the usage of helium.
Okay, thank you.
Thank you very much.
So next up, we are supposed to have a talk given by Fabian Niss, but due to his maternity leave, he was not able to attend this year's workshop. Instead, Wolfgang Bogner will introduce his work on non-invasive 3D mapping of downstream brain glucose metabolism using proton MRSI with deuterium labeling at 3 Tesla.
Can you hear me well? Okay, thanks a lot for the introduction. I will give this talk on behalf of Fabian Niss. I hope I will do it justice. We have already heard quite a lot about deuterium metabolic imaging, so I will keep this brief. Obviously, this deuterium metabolic imaging would be a great biomarker. The current gold standard is FDG PET, and there are, on the one hand, deuterium metabolic MR spectroscopy imaging and 13C-based MR spectroscopy. The advantage is, for example, that they can not only quantify the glucose uptake, but also the aerobic and anaerobic glucose pathways. And there have been a couple of publications related to clinically and on preclinical scanners, including the first two here by Lu et al. And Beta et al., of course. And what was also briefly mentioned in the first presentation, there's an alternative technique called QUELT, which indirectly allows you to observe MRSI, or deuterium metabolic labeling. And also the basis of this have been presented. As far as I know, there are also is current work in preprint by Anke's group. And also we have recently got a paper published on this work, and I will briefly show what we have shown here for single voxel spectroscopy, but we have also shown MRSI. So briefly, if you directly after glucose ingestion, you can observe such a spectrum with single voxel spectroscopy at 7 Tesla. Then after 1 hour, you can get this, and you can make a subtraction. And then you have slightly better spectral resolution, and therefore you can also try to separate the different deuterated compounds. And here, unfortunately, not well phased is a direct proton MR spectroscopy. Here, just briefly, how this looks dynamically. You have excellent spectral quality throughout, and when you do the different spectra, always compared to the first one, you see that the GLX4 resonance shows up. And here a direct comparison in pretty much the same voxel, but slightly different voxel size for Deuterium MRS. Unfortunately, these are 7 Tesla data, and although the advantage of the QUELT method is that you don't need special hardware
7 Tesla MR scanner, so it can still be considered quite special, I would say. That's why the aim of this study was to investigate whether that's feasible also at 3 Tesla. And now we have only focused on MRSI, metabolic imaging, and not on single voxel spectroscopy, but certainly that would be even easier. So we used the 3 Tesla MR scanner, 64 channel receive Siemens coil. We had only 7 participants because it was just a feasibility study. We gave them orally 0.8 gram per kilogram deuterated glucose. In parallel to the MRSI acquisition, we performed capillary puncture blood glucose sampling. We started everything to be very consistent with an auto-align localizer and EPI calibration scan, which we afterwards used for real-time and stability correction. I will come to this immediately. And then we used the method that we published in 2020 by Mosa et al. And this is essentially real-time motion Schimann frequency corrected 3D FID MRSI sequence. Cannot really go into the details here, but we combined this with this concentric ring trajectory readout based FID sequence that we use quite regularly at 7 Tesla also. And we briefly optimized it for a 6 millimeter cubic voxel volumes. That is not high for proton MRSI, of course, but it is somewhat higher than what direct deuterium metabolic imaging typically achieves. And the point why we went to a relatively low spatial resolution was that we wanted to go to a high temporal resolution of 4 minutes to accommodate 14 3D data sets over about 60 minutes scan time. And here's just briefly illustrated here directly before the subject was going to the MR scanner. They were drinking orally deuterated glucose, and then we performed the 14 consecutive MRSI scans. And then at the very end, we acquired an MP2 RAGE to obtain ROI definitions and gray matter, white matter masks. Then we did the standard post-processing based on MATLAB, which included K-space convolution grading and weighting and noise decorrelation, lipid regularization, L2 based, and then our standard core combination. And we processed everything using our standard pipeline with LC model over this spectral range, but we had to slightly modify the basis sets because of the 17 typical metabolites that we included. We needed not only a fixed macromolecular contribution, which was measured before, but for glutamate and glutamine, as well as for glucose, obviously, we needed to make some modification because only the glutamate 4, glutamine 4, and glucose 6 resonances were actually labeled and going to be changed substantially. And the rest were essentially unlabeled, and these were more or less separated in the basis set. And then we did standard data evaluation using Python scripts, and also the statistical analysis and plotting was done by this. And then here are some results of these 7 volunteers to just briefly see how that it's pretty stable. You can see the drop of the GLX4 signal here over time. This is a considerably more change than, for example, for a functional MRSI experiment. And here you can see also the time courses for the glucose 6, which are also reduced over time, but slightly less stable than the GLX signals. And then here's some sample spectra that I show here, one for the gray matter and one for the white matter. For visualization purposes, they are first order corrected. And you see also there's a model fitting. And this is not first order corrected. You see there's a slight first order phase error here. But when we do the subtraction here, for example, for this, I think the spectra summed up over a region of interest here, then you can see in the subtraction spectrum somewhat also the elevated GLX4 and glucose 6 resonance here, both in the gray matter and white matter. And then here you see the time courses. So in GLX4, you can see both in the gray matter and white matter a fairly stable decrease. So it's about 50. I mean, it's not absolute quantification, it's just an arbitrary unit per minute. And here you see about 37. And then these are highly significant statistically. And then here you see also the same fits for the glucose 6 resonance, where there is in the glucose or in the GLX4 we see a bigger difference between gray and white matter, which is not as big in the glucose 6, at least not in the group analysis. And then here you can see when comparing the first and the last time point, the significant drops are only in GLX4 and GLC6, but not in the other metabolites. A couple of them are shown here. And here are the baseline glucose scans that we have performed. So we we're going from a baseline level from 86 to about 26 roughly in all the different subjects. And then it's going slightly down over time. Then we also went away from RI-based analysis because it would be quite nice to be able to do this slope analysis, also voxel-wise, and we can see here in these slopes somewhat of a gray matter white matter difference in the GLX4 maps. That works less well in the glucose 6, but the vast majority of the voxels we see are having p-values below the significant level. And if you just look at this one example, we also see here a significant difference between gray matter and white matter. And here's another plot just correlating essentially all the time points of the gray matter and white matter RIs for the GLC6 concentrations versus the GLX4 concentrations. And I'm already at the conclusions. So we've shown that the dynamic 3D resolved assessment of deuterium leveled glucose and downstream metabolites in the human brain is feasible at clinical 3 Tesla. There's obviously space for improvement, but it's a first step. The nice thing about this would be that essentially you can go to any 3 Tesla MR scanner. Potentially, maybe you can go to a 1.5 Tesla MR scanner and do this experiment and repeat it there. There could be, as we said in the beginning, it could be used as a valuable additional biomarker for various pathologies. And as we have also heard, the methodology is not limited to glucose. For example, it could label choline or something else that's visible in the proton spectrum, of course. And that's basically it. I hope you found it interesting.
Are there any questions from the audience?
I think it's really amazing you can do that with deuterated glucose. Do you mind us over what time period you are following the metabolism for?
I mean, this was just for testing the methodology, and we just did it for slightly more than 1 hour.
Okay. But it looked like the GLX production was linear over that time period. Wouldn't you expect it to reach steady state?
Yes, we have experimented with both. So at the 7 Tesla, we have also tried to fit exponential curves. That's an open question. I think we need to properly also maybe include also a baseline and then also measure longer to properly model this, in my opinion. From what we have seen in these data, and also we did comparisons to the direct deuterium over the small time course we had, it looked more linear, and it's also was more stable to fit than the exponential time course, because that would require you to have, I think, also a more stable baseline measurements. And that's why we chose here just those. But if you look a bit more in detail, it's not exactly linear.
Any more questions? If not, thank you very much for that amazing presentation, Wolfgang.
Oops.
Our next speaker is Simone Poli. GMI using different doses of 6'2H2 glucose for real-time in vivo liver glucose mapping at 7 Tesla.
Thank you. Thanks for the introduction. So what I'm presenting you today is an extension of a clinical validation study that we are completing in Bern, and it involves DMI, so deuterium metabolic imaging, where different doses of double deuterated glucose. I would like to start with some background. And inside the human body, the liver plays a vital role in the glucose homeostasis. Now, in terms of uptake, storage, and release, it is in particular important in pathological cases, so type 1 diabetes, type 2 diabetes, post-bariatric surgery patients, to have a better understanding of the hepatic glucose metabolism. And it is thus of high importance to have tools that allow this quantitative, non-invasive exploration of hepatic glucose metabolism. Previously, deuterium metabolic imaging, or DMI, has emerged as a tool with a lot of potential that allowed to assess in a dynamic way the fate of glucose, deuterated glucose, after the administration of deuterated glucose or potentially other substrates. You already saw an introduction about DMI a couple of times recently, but I'll just go fast through those points because I think are important. So DMI, it relies, as I said, on the oral administration of deuterated glucose, where deuterium is a stable non-radioactive isotope that has a low natural abundancy. So we have a technique that does not require water suppression, as it's often the case with proton spectroscopy. It has a nuclear spin of 1, short T1 relaxation. So we have a technique with good MR sensitivity. And yeah, it resonates at a relatively low frequency at 7 Tesla. So we have a technique that is robust against magnetic field inhomogeneities. And it was shown recently that the SNR of this technique scales supralinear with external magnetic field. And that's the rationale why we are applying this technique at the highest magnetic field available in our facility. First application was done in a preclinical study in 2017. And very famous application 2018 from Fighter, where after this administration, the fate of glucose, GLX, and lactate are traced over time. In our application, we use deuterium metabolic imaging inside the human liver to have information, spatial information about deuterated water and deuterated glucose signal. We can obtain as well water and glucose metabolic maps, or glucose over water. So we take in consideration the sensitivity of the coil. And if we apply this technique over time, we can have a kinetic understanding of the deuterated water and deuterated glucose evolution over time. It is suggested in the literature a dose, an intake of 60 grams per patient, or 0.75 grams per body weight. In our clinical study, we use 60 grams. As you discussed before, it has its deuterated glucose is pretty expensive, can cost around 18 Swiss francs per gram. And on top, we are looking at pathological conditions. So in certain patients, and we had different cases, there is a difficulty in the ingestion of such a high quantity of deuterated glucose with refluxes and so on. And the gastric emptying, of course, it takes more time. So it needs more time for a complete absorption. So the goal of this project is to explore the feasibility of lower than suggested dose of deuterated glucose for dynamic hepatic glucose mapping. I will go fast in the study design. There's a lot of information. I will just point out the most important one. First of all, the population that we are looking at. So we have 2 subjects that had a full intake of 60 grams of deuterated glucose. Then we had 2 with 20 grams and 2 with a dose as low as 10 grams. And our patient, they goes into a first period of standardization, and then they have the day of the examination, MR acquisition and blood sampling performed concomitantly, so at the same time. And here I just want to point out the fact that you can see that we have in our acquisition, like around 3 hours of acquisition, interleave scans of deuterium MRSI, because we want to have information about deuterated glucose, but we also acquire carbon-13 MRS, because to have a full picture of the hepatic metabolism, it's important to be able to have information about the natural abundance glycogen in the human liver. I'm already in the results part, so I really want to show the spectral quality that we normally obtain with 60 grams. So here it's 6 central voxel from the liver, from a patient, from a subject that had 60 grams of intake over 4 different time points. And as you can see, at T0 before the intake, we don't see anything else than deuterated water. And if we, at T0, they drink the deuterated glucose, and we start seeing on the right side of the water a second signal, that is the deuterated glucose signal, that reach maximum around T60, and then it starts decrease again. For the 20 gram and the 10 gram population, we can see in the spectra that we have a similar behavior. Of course, the deuterated glucose signal is proportional to the fact that we have a lower intake, but in the 10 gram population, that is the one with lower dose, we can still see at T60 a clear signal separated from deuterated water, and you can see it here. And if we go over the whole participants of the study, again, I'm plotting the results from the 60 gram population, the 20 gram population, and 10 gram population, 2 subjects per population. And starting with 60 grams of intake, you can see here in red, it was red, here it's red, another color. You can see that before the intake, we don't see any signal. And then when they drink it, we have a rapid increase that results in a maximum signal around T70, 80. And then we start to see an increase. And here it's shown also the deuterated water signal that it's increasing. So it's shown that it's an end product of the TCA cycle. And I would like to focus on the 10 gram population, and it is the one with lower intake. And you can see that the behavior that we were seeing in the 60 gram is respected. So we still see an increase. We reach a maximum around T70, and then we see a decrease again. It's remarkable that even with such a low dose, we're able to fit. We don't have issue in that. And we can see a clear signal here, while on the deuterated glucose signal, the deuterated water signal, sorry, it stays constant. As I said, for certain studies, information about deuterated glucose is not enough. We are looking also at glycogen, because it's important to have a full overview of the hepatic metabolism. And we are looking at the natural abundance glycogen. So it's already a signal that with 60 grams of intake, it's a bit tricky to obtain. But with 60 grams, we are seeing an increase. So in this case, we see an increase of around 10–15%. But no way that we can do the same with an intake of 10 and 20 grams. So just take in consideration that this technique, it's working for deuterated glucose. It's fine to lower down the dose, but if the aim is also to look at other metabolites, then it might be a bit tricky. Unfortunately, I was not able to participate to find the cow, but I still want to bring some credit to the game, so I'm just showing a single slide for her, and I go towards the conclusions. And to conclude, we show the feasibility of deuterated glucose as low as 10 grams for liver DMI, and this is beneficial in our case because we can see a whole dynamic of increase and decay to baseline of the deuterated glucose signal. And since our next step is going to be metabolic modeling, that's very beneficial. and this reduces the cost. And if the MI is going toward the clinics, being able to spend 1/6 of for the intake of deuterated glucose is beneficial. And in particular, when we have pathological subjects, for them by experience it's easy to intake such a lower dose of deuterated glucose. But we still need to keep in mind the fact that for other metabolites, we might have a decrease in the detection. And with this, I want to thank you for your attention.
Thank you very much for the nice talk. Questions?
Great presentation. I was just wondering if there is any other physiological effects after 3 hours in your measurements, like
I mean, they're laying down. It has been proven that the gastric emptying does not play a role if they're sitting or if they are laying down. So from that side, you should be okay. Yeah, I mean, in the full study, we had some dropouts because the scanner is uncomfortable, and everybody knows if laying down in a scanner for 3 hours can be very long. But yeah, I'm not fully aware of it, but yeah.
Thank you.
Thank you.
Any other question? Okay. Yeah, we have one.
Very nice presentation. Thank you. I have a question about the glycogen. Would it be an option to use just this 40 grams extra as unlabeled glucose, or is there anything against that?
Depends what you want to do, because if you're looking to have a fast gastric emptying, then of course you could substitute the other 40 grams in carbon-13 rich glucose, no? If that was the question.
Yeah, exactly. Yeah.
But still, the gastric emptying, then it's happening like having a full intake, no? Yeah. And we would have higher costs because from what I know, carbon-13 glucose is more expensive. Yeah. And
I actually thought unlabeled glucose, which is cheap.
Yeah. Yeah. Then okay. Apologize. Then it's for sure an option. The gastric emptying would be the same, and maybe also the difficulty for the patient to intake would be similar. But that's
Okay. Thank you very much.
Yeah.
Okay. Any more questions? Okay. Thank you.
I enjoyed your talk. Mike, I just had a comment. I thought it was striking that you, on the slide, you said at screening there had no caffeine.
Yeah.
And then you managed to get them all through without them.
Well, I could not take anyone in this conference for considering the amount of caffeine we had. I agree. But you need to standardize the diet.
I agree. It's just, I've had a lot of trouble. It's hard to convince, especially healthy control.
Yeah, that relies on the clinical side, and they did a good job in that. But it's needed, otherwise the interpretation is impossible. So they have 48 hours of diet standardization, where they communicate with the doctor exactly what they ate. And so we hope they stick to the plan, then it's not 100% sure.
Just a comment to these different doses of glucose. It will not only be a mass amount of glucose you are changing, but it will be also a different insulin and glucagon response you have in the organism. So then the comment of Vera of giving this additional unlabeled glucose would help for better comparison of those two experiments in respect of the glycogen or labeling or whatever.
Yeah.
Thank you very much. So with that, we'll move to the closing presentation of this session. Last but not least, Antoine Chéry will give us a talk about anesthetic-related neuroenergetic changes measured with proton and phosphor
MRS in mice at 7 Tesla. So it's my pleasure to be the last speaker here. I'll try not to bore you for too long, as I'm sure you're in a hurry to go home or hike or have more coffee. So I'll try and keep it short and go to the point. So in this study, we're interested in looking at the differences in brain energy metabolism between two different anesthetics. And in particular, we were interested in the effect of medetomidine, which is becoming more and more popular, especially because it has the ability to maintain some sort of functional connectivity in fMRI. But spectroscopy is also starting to be interested in that anesthetic compared to the previous trendy anesthetic, which was isoflurane. And the reason being that isoflurane has this downside that it has leads to accumulations of lactate that aren't very clearly understood. And as was presented by, as was presented by Moore a couple of minutes before, but it's been suggested it also leads to changes in energy homeostasis. There have been reports of changes in the phosphocreatine to creatine ratio in different studies. And so that's more problematic if you are interested, like me, in studying energy metabolism. That work now, yeah. So the goal was to basically compare at steady state energy metabolites between these two conditions, so medetomidine and isoflurane. And I should specify that it's not just medetomidine, but medetomidine with a little bit of isoflurane. So the protocol basically was to use one anesthetic and to switch to the other one within the same session. And I'll explain later why we use that protocol. But because with that, you might induce some effect of duration of anesthetics, we had to have two groups, one starting with isoflurane and then switching to medetomidine and vice versa. And so we had two cohorts of mice. The first one underwent proton spectroscopy to look at specific metabolites. So obviously we're interested in lactate, but also some neurotransmitters and phosphorus spectroscopy, because that really allows you to measure energy homeostasis. So a bit more detail. So we basically did everything in C57 mice at 7 Tesla. So for proton spectroscopy, we used a voxel that was around the hippocampus mainly, using cryoprobe and an edited sequence mega semi-laser. And for phosphorus, it was a slightly bigger voxel with a transceiver surface coil designed by Paul Steck using 3D ISIS. And we analyzed everything with MRS. So we first looked at physiology, obviously, and we know that there are some changes that are expected between these two anesthetics. So what you're seeing here as the green trace is the group that started with the medetomidine, and then after these red line switched to isoflurane, and the blue the other way around. And then if you reverse this green line, and average these two traces, you get some sort of trace that is independent of the anesthetic time. And you could see that when comparing the average before and after, so as a paired test, there was a significant difference in the heart rate, which is something you'd expect because medetomidine affects the sympathetic nervous system and reduces the heartbeat. While we didn't see any changes in the blood oxygenation, but a change in respiration that was very clear and nothing very obvious in terms of temperature. So then we looked at the metabolism in the hippocampus, and we did see a clear change in lactate with this protocol, but in no other metabolite. And we did look at the phosphocreatine to creatine ratio, but as you obviously see, and I would be the first one saying that it's not the way to look at this ratio at 7 Tesla. You can't really separate it out, so it's not really reliable. And so we decided to do phosphorus spectroscopy, which I'll talk about a bit later. Before that, we also tried to look at whether there was a correlation between the level of these metabolites and the physiology, and well, we saw changes in the correlation with phosphocreatine, which I won't comment on based on what I just said before. But we did see, interestingly, correlation between the lactate and the heartbeat, which is obviously hard to interpret, but might suggest that this lactate relates more to blood flow rather than oxygenation. And so we then did the phosphorus spectroscopy, which required a bit of implementation. So we did try different protocols because we thought that at 7 Tesla we might benefit for slightly longer T2s of some metabolites, and we tried semi-laser, for instance, which didn't perform better than the good old standard 3D ISIS. So we went for that protocol instead. And so we try and optimize the acquisition time and looking at the errors of the quantifications, and found that around half an hour scan allowed us to look at all the metabolites that we cared about, which is phosphocreatine, ATP, and inorganic phosphate. And to convince ourselves that we can measure changes of these metabolites, we did a test-retest experiment to measure the variation with different protocols, so a between group comparison, between session or within session comparison to get some power calculations. And so this comforted us in the idea that we can measure changes with this phosphospectroscopy protocol with standard group of mice. But it also suggested that doing within session comparison is probably more appropriate to look at smaller changes in the brain. And that's why we did this switch in the anesthetic, as I mentioned before. And here are the results. So basically, we didn't see any change in energy metabolites, so ATP or inorganic phosphate, which suggests that homeostasis is maintained. However, we did see a drop in the pH in the isoflurane condition, which sort of makes sense if you see an increase in lactate. And yes, that's the main result. So of course, interpretation isn't necessarily easy because it's steady state measurements, but it is clear that the ratio of phosphocreatine to ATP and inorganic phosphate seems to be comparable between these two conditions, which strongly suggests that homeostasis is maintained. But because we do see changes in lactate and a drop in pH, it's really indicative that allostasis isn't maintained and that there are fluxes that are different. And of course, this is harder to interpret, and our study doesn't really explain what's happening. One explanation that could be a glycolytic switch, so a reduction of TCA cycle, as has been shown by others, that TCA is proportional or inversely proportional to the depth of anesthesia. And we also know that isoflurane creates a strong pyruvate to lactate production, so maybe something related to LDH. But yeah, it will need more experiments, and of course, carbon-13 dynamic experiments are going to be very useful for that. So to summarize, isoflurane did drop the respiration and increase the heartbeat. It did not alter energy homeostasis, which was what we were really willing to know, which is a good news. But it did increase, indeed, the lactate with an associated drop in pH. So I think future experiments should try and understand what is really causing these changes in lactate. There's already a lot of studies who've been doing that. And whether it is simply a glycolytic switch or if it's independent of the TCA cycle, or more what we call a Warburg effect. And with that, I'd like to thank all the people who were directly related and indirectly related, and you for your patience and your attention. Thank you.
Thank you very much, Antoine. Are there any questions?
Thank you very much for this nice talk. So do you think that the differences in lactate that you detect, is this purely a difference in lactate synthesis rate in the brain, or could it also be differences in or changes in lactate production in the rest of the body and then transport to the brain?
So I don't know, because our results don't show that, but indeed that's very much a possible explanation as well, It could be a change in diffusion of lactate, change in permeability of the brain, or it could be just local, and even just the change in pH doesn't necessarily indicate that it's in situ, I think. So yeah, the question remains, I think, but it is yeah, a valid point.
Since I'm younger than Ivan, I will go first. Very nice talk. But now what do I do? Can I still continue using isoflurane, or you want me to go to the other mixture?
So I think it really depends on what you want to do. I guess if you're interested.
I'm afraid of this answer.
So I think, yeah, that's really the point in the end, is really dependent on what you're interested in, what you want to look at in the brain. And well, I'm personally interested in energy metabolism. So of course you want to try and be in some sort of most homeostatic way as possible. Or at least you want to know what is going on, and doing these very basic studies between anesthesia is really important to sort of know what are the different factors that could influence a result. Whether these changes in creatine phosphocreatine that we sometimes see is really real, or might be actually related to your physiology and maybe the monitoring of your animal. So I don't have a clear answer.
Yeah. Coffee?
Yes, always.
Do you think that it is a change between two different steady state because due to those two different anesthetics, or if you continue, let's say, with isoflurane, the lactate will go up, you know, higher?
So the dynamics of
yeah,
whether
so,
it.
So do you think it is just simply between like two different steady state and it goes up and stay there, or it may go up?
I do think that it is a change between two steady states, but well, we can't measure everything either. So it's two steady states at the very purely metabolic way. Maybe there's some change in blood flow that obviously we're not measuring that might not be affected by the switch. The wash out of isoflurane might be slower. So yeah, I don't really have an answer to that. We've not done that experiment, but indeed that could be interesting to just try one anesthetic on its own and see also just the effect of the duration of the scan. Yeah.
I don't know. Yeah, so thank you for a great talk. It's rather a comment and maybe an answer to the question of Christina. So Christina, I think so we cannot change actually isoflurane to the metadamedine, because metadamedine has an anti-inflammatory effect. So we have to pay attention whenever we do the study with some inflammatory disease like Alzheimer and the other like Parkinson or neurodegenerative disease, because this will influence the data. This will change the inflammation state of the brain. So we have to really pay attention to this, which type of anesthetic we are using. So this is just my comment to all.
Yeah, that's a good point. Indeed, you have to adjust it to your experiment. Yeah.
Yeah, just adapt the anesthetic to your experiment. Do not influence your data.
Maybe just to add up to the other question that were here. So we did some, because we tackle a similar problem with the different anesthetics that become the new protocols. So we did some preliminary data experiment with giving a bolus of lactate. And we actually see that when we use isoflurane, there is increased doing proton spectroscopy in the hippocampus. When we gave a bolus of lactate, we see a trend of higher lactate in the case where we anesthetize the animals with the isoflurane. So we believe with this data that it's probably not a brain-burn lactate, but rather blood-burn lactate that was entering the brain. And in related to the steady-state experiment, I didn't talk about it with the limits of time, but with the experiment that we did with the Deuterium MRSI, we saw that the dynamic of glutamate-glutamine combination is faster in the metabolic isoflurane case compared to the isoflurane alone. So in the steady state, we couldn't detect in the proton spectroscopy and also in the SAM analysis the difference between the pool size, but probably the dynamics of the metabolic pathway is different. So probably it's wise to be careful and report also the kind of anesthesia we are using, because it's not just immobilizing the animal, it's also have different systemic effects and affecting also the dynamic of the metabolic process.
Yeah, that's a good point as we discussed the other day. I think yeah, no protocol is perfect, and that's why it's important to have different approaches to try and understand better what's going on.
So if there are no more questions, thank you very much. So this concludes our session on emerging techniques. To end this all, I would like to thank the audience for participating and asking questions. And I would also like to thank all the presenters who took their time to prepare some really nice presentations for us to enjoy. Thank you very much. So with that being said, I think Wolfgang has some closing remarks for the workshop.
Thank you. Yes, please don't run away yet. I have a few words to say, not much because I need to get my flight. And there are also some open questions. First of all, I hope you all enjoyed the workshop. I certainly did. I can briefly tell you why. 4 years ago, we had our last workshop in Utrecht. I think of those who were there know right after we had a discussion whether we should have the next workshop 1 or 2 years after. Didn't quite work out. It's now 4 years. I think we did a pretty good job in bridging that time with a couple of virtual workshops, virtual conferences, and so on. But I don't know what's your experience, but I think it's just not the same. It's nice. Probably we will keep this because it's a nice add-on, augmentation. But I'm very happy that we are back to the old normal, not the new normal. And I think this was already not good for the community overall, but I think it was particularly bad for newcomers. Just imagine that you were joining the field, become a PhD student. 2018, for example, you were maybe not able to already write an abstract that could be shown 2019, then you maybe didn't contribute or couldn't join the ISMM conference, and then you had to basically wait until 2022. 1 more year, and we would have a whole generation of PhD students that have never been actually present physically at an international meeting, which would be really sad. So that's why I think it's so important that this year we had this ISMM conference and of course also this MR spectroscopy workshop. And already now I had quite some good feedback from PhD students who were really happy and said, this is important for exchange, getting new ideas. I still remember how important this was for me in the first years. Having said that, how important it is, I want to thank those who really made this possible, all the organizers, both internationally and locally. And that includes in particular, of course, Christina, who spearheaded this organization. Also, she had a lot of help, also, for example, from Bernard. I cannot go to all the names, but I want to point out also the early career researchers that helped make this possible. Junja and Jesse standing over there, for example. And I think they need another applause because this was not organized as an ISMM workshop because we wanted to make this really affordable, to make it possible for many to contribute. I think it is very successful. And that needed extra work by the local organizing committee. So that requires certainly another applause. And so for those who don't know, we had, I think, almost 150 on-site participants. And I think another almost 40 joining virtually. I think that's quite a respectable number. And now there are 2 remaining questions. We don't need answers for both of them. The first one is, who is going to make and organize the workshop in 2 years? You can raise your hands right now, but I don't want to push you. Think about it, and you can approach the MR spectroscopy study group committee. And then the second, at least equally important question that needs to be answered is, but I'm not going to answer this, who actually won the cow game? And these two ladies over there will do this right now.
Yeah, it's going. Yeah. So thank you, Sarah, for making this PowerPoint. So she collected all the slides from the speakers, most of them, so you can see the ones you missed. Yeah, so it's gonna go in a loop. So first of all, I would like to thank Mladen for the original idea and Roland for proposing to continue the idea. So this was, yes, as you can imagine, a great, yeah. Yeah, this was really tricky to score, but thank you very much, Dunya, for helping with this. So we have a so we will have 3 winners, and the gift is the real Happy Lily cow in wood, and some goodies from EPFL. So I would like to thank all the speakers for playing the part of the game. Yeah, some were more obvious than others, and some were really on point. So now I will announce the 3 winners. So yeah, I missed this one. Yeah, maybe you want to see the slides first. Okay. Yeah. So we missed a few presentations, but yeah. So yeah, thank you very much. Almost everyone participated in this challenge. The few who did not was either a mistake from us for the email sending at the beginning, or last minute removing of the slide. So now I will announce the 3 winners. So the 3rd place goes actually to the inventor of the game. Yes, Mladen Rakic, right? Congratulations. Yeah. Yeah. The 2nd winner is Inge van Ooyen. And the 1st winner with the best score is Antonia Schuschniar. Quite a lot still. Yeah. Okay, so thank you everyone very much, and I hope you enjoy your more present.
So hello. So I'd like to thank you all for joining and coming to Switzerland for this great event. And this would not be possible, as I've said in the first speech, without Christina and the other co-chair, which I'd like to invite to the front.
And I would like to invite also the local organizing committee because they did more than a fabulous job. It's really a close-knit group, and the teamwork really felt like it was the day and night, and they did an amazing job. Thank you very much for representing CIBM and for hosting this great scientific meeting.
Yeah, we have a photo and then maybe we can. More. Now we start. No, okay. Yes. There's only one. Well, please join. Okay, thanks for entertaining this last minute thing. Okay, thank you very much.
Sports.